So once you dissect out the posterior area, gently dissect out, and subsequently you can take out this piece of tissue without any requirement of forceps once you detach it from the areas attachment. So with this same spoon, I can take out this with little rotation, just take out, it comes out. So this is how simply it can come out, effectively can be done. These are definite learning curve. These are various things you should know what all complication or a difficulty can arise. Classically seen in these cases of smile is a black spot, which is very, very common, routinely seen, opaque bubble layer, cap lenticular adhesions during dissection, retained lenticule, and the extension of side cut. But major challenge is the suction loss, which can happen because, as Dr. Manpreet said, it is a very light suction onto the cornea where the patient can see the entire thing happening. The light fixation can be seen. There is no, you can say, compression or optic disc circulation also. That's a better part with this particular suction, which is created in smile also. So this is what we talked about. First you do anterior dissection, then you do a posterior dissection. Sometimes you miss the dissection, and that can create the complication, because once a dissection is difficult, all complication related to the dissection and the side cut increases. If you see here, retained lenticule, delayed visual recovery, cap tear, side cup tear, posterior stomal damage, epithelial defect, irregular astigmatism, these are going to compound your recovery of vision for patient as well as the poor quality of vision in these cases. What are various signs you should know that you have actually dissecting appropriately? This is a meniscus sign. Normally we tell that anterior dissect to one side, then dissect the posterior to other side, so that you have two separate zones of creation of a pocket. And this is possible for if your incision is 3 or 4 millimeter. If your incision is 4 millimeter, so you have to just ideally do it and nudge this dissection to create the meniscus sign which we described, and this meniscus sign tells you that you are at least posterior to the lenticle side also. If you see here, that is what I am showing here again. So this is where I have done the anterior. I am trying to see the posterior part which is not visible. So what we'll do, we'll dissect lift the edge of a lenticle. You can see I will go reverse instrument. Just lift it because it is attached to the cap. So once I detach this, I have a space now. I'll just go anterior to this. In fact, many people start like this only. First they dissect posteriorly, then go anteriorly. So both ways can be done with your experience, and same thing can be achieved. So this is the outcome for our patients. Let me just show you the results of long-term results of smile patients, because that is important for all of you. As I said, these are our various publications of early learning curve, then complications, then how to do effectively. Then this is a smile book, one of the first book in the literature on a smile. People can acquire this book also. Let me tell you what have been our results. That is to be known. So we have around 140 patients who have completed 7 years of follow-up, which is quite a longer follow-up. This will be published subsequently. You can see our age around 25 years, around 5.4 is a refractive error, and astigmatism is slightly lower, because normally for smile to begin with, we were not taking very high astigmatism. Now with the newer generation system, which has a tracking also, you can have cyclotorsion adjustment. With this also, you can take a large degree of cylinders also. So that advantage of LASIK is also now with the newer generation smile or lenticle-based surgeries also. So these are our visual acuity results, quite a significantly better results. If you look into 7 years, we have a mean regression of hardly 0.12 in these cases. So which shows that smile is a very stable procedure for long term also. If you look into efficacy and safety, it is really efficacious and safety, as you see in the LASIK patients also. Spherical coma induction, you can no significant change in the visual quality over 7 years. In fact, in smile, as a patient goes from 6 months to 1 year, 2 years, the quality of vision improves. So that is a real quality which we see for patient. While PRK, LASIK, we are not sure how much regression happen in these cases also. This is the only study in literature which has a 10-year results. There also you can see long-term results of smile is quite comparable and quite good in these cases. For a higher degree of myopia also, people say we will not do for very high myopia. This is again is a very, very effective surgery for a higher degree of refractive error also. Quality of vision, lesser induction of higher order aberration, which is documented in these cases. This is all series, biomechanics also, they are quite stable. And the complication-wise, we hardly had complication after we crossed the 50 patients. That means around 100 eyes, no suction loss, no difficulty in dissection because you know how to dissect both anterior posterior in these cases. So this is a little surgically challenging case for beginners, but as you cross 50 eyes, you tend to do quite effectively in these cases. The dryness also. See, this is very important point here. At 1 month, around 60% will have some sort of dryness. But see the results at 7 years, only 7% people require artificial tears. So that's a significant achievement for any refractive procedure, in fact. Retreatment also, as Dr. Manpreet talked about, is not very well established. No, we have various ways to treat retreatment in these cases also, but the requirement of retreatment is very, very less. In our case, it's 0.7%. I have only done 2 retreatments after SMILE procedure. So that shows how effective this surgery is, and people should opt for this. The long-term results of SMILE is comparable to any other procedure, in fact better than a LASIK or PRK in different degree of refractive errors. And if I say with the titrating point is, one is the ocular surface, dryness, second is the stability of refractive error, and lesser induction of higher order aberration. These 3 things are very important for lenticule-based surgeries, and in fact, this is going to be a long-term better outcome. You will have to do these surgeries in future in patient all coming for a laser refractive correction. So I think as far as I'm concerned, all surgeries are good. SMILE may be preferable for these cases except for hyperopia. Thank you. And this is one book I think we must have, Refractive Surgery, which is very popular. I think we have already sold more than 20,000 copies. So people can go for this. Very good for exams. Thank you for kind listening.
Thank you, sir. Okay. So, thank you. As you can see, that is a very nice simplified overview of the SMILE technique. My next lecture, it's my pleasure to invite Dr. Sudhang Bharti. This is a very, very important area, which is refractive surgery advances. Meanwhile, if anybody has any doubts, you can ask 1 or 2 questions while Dr. Bharti is setting up the slides. Okay. So far, everything is very clear, it seems. Good.
Thank you for inviting me here. Thank you very much, Doctor. I'll be talking about recent advances in refractive surgery, and okay, and but primarily today the lenticule procedure is the best thing as of now. So I've been doing LASIK for more than 2 decades, and then after that everything is now boiling down to a situation where the lenticule procedure has become so accurate, both as the refractive correction and for everything except hyperopia, compound astigmatism, and probably in those cases where indication of PRK is there. For all these other indications where LASIK was the first choice, probably it has changed to lenticule. But anyway, the issue with the refractive surgery and this advances is the safety and efficacy of any procedure. And as Professor Titial mentioned, eye tracking system and the centered treatment is the most important fact, because that, if it is decentered, causes coma and poor vision. Cyclotorsion compensation and induced spherical aberration are other factors which are important, because if you have induced spherical aberrations, the quality of vision is not so good and the patient is unhappy. Induced astigmatism is one factor which is there in SMILE and is not there in the newer generations of lenticule procedures, And astigmatism nomogram is there, where there is undercorrection of high astigmatism or cross compound ablations, especially in LASIK. The refractive surgery armamentarium, the surgeon has a possibility of doing PRK, LASIK, lenticule like SMILE, and the one which I am going to talk, the Clear, and the new things which has come Silk. But as of now, Clear has major advantages above everything else. Phakic IOLs, inlays, refractive lens exchange, refractive cataract surgery, and cross-linking. So the important thing is there has to be a optimized visual acuity and patient satisfaction, which is of paramount importance. And for high astigmatism, SMILE, femtosecond LASIK, and PRK have similar effectiveness and safety. The only important fact is that SMILE induces more astigmatism as compared to any other of these three. Now I'll come to the procedure which I am practicing for last about 4.5 years. I was instrumental in doing the initial studies of 2.5 years, where I did 41 patients for the company, and finally we came down to the formula and the software which could be now sold in the market. So in last 2 years the market is having this software for Clear. It is a flapless. The important thing is there is auto-centration, auto-pupil capture, auto-centration, and auto-axis alignment. These three factors make it much better than any other lenticle procedure as of now. There are guiding tunnels for gas bubble venting, and when there is gas bubble venting, there is no possibility of gas bubbles going up or going into the antechamber. And then incision option, there are possibilities single incision or double incision. And when you are in the early phase of learning, you have double incision, one going into the anterior part of the lenticule, the second going into the posterior plane of the lenticule. And when you go into those incisions, you go straight into separating the anterior and posterior planes. There is intraoperative OCT, and there is overlapping spot scan and very low energy, as everybody knows. So this is the first video. All videos are very small, hardly 2 minutes each, but they'll explain the procedure very well. So this is how we are correcting. In this particular case, you can see the astigmatism is 4.5, and this is one of the first few cases in the when the software came into commercial availability. And here, if you see, when the docking is there, the whole procedure is about whole area from here to here is about total 8 to 9 millimeter. So once you have docked, you see the pupil is captured automatically. There is absolutely nothing you need to do to capture the pupil, and axis 180, 180 is also marked, where there is absolutely no problem. This is the main port which is shown here, and then the lenticule is created. First the posterior plane of the lenticule, and these are the two lines which are showing that it will have these are the gas bubble venting tunnels. The whole cutting of anterior and posterior lenticule planes is 25 seconds. So this is a very quick procedure. First the posterior and then the anterior is, as in any other lenticule machine, is done. And then you can see that these venting tunnels are connected so that there is no possibility of gas bubble going anywhere except in the remaining in the planes which are there. And then now you can have the option of having this OCT post-operatively, post-finishing the lenticule extraction, or you may not have this thing. It's your choice. So it takes another 10 seconds to have that capture. So I sometimes just don't do it. It is not necessary to have the OCT. And then this is no. I don't know. So this is a complete film, and you can see that there is auto capture of everything, and the lenticule formation. This particular case is not so high astigmatism, but this is a normal case of 2.75 with 0.5 cylinder. So this is not much of an issue, and mostly you can comfortably correct up to 8 diopters of correction in a lenticule procedure, depending upon the thickness and corneal profile and all corneal biomechanics which you have done, and Dr. Manpreet has already elaborated on the pre-op workup. And once you have found that all these things are okay, then you can go up to, and I have corrected up to -8, but I don't go beyond -8. This is how this the eye looks once you have removed the docking, and then the separation and other things are absolutely same. The only thing is that the software is different, and software is much friendly for, especially for the correction of astigmatism and auto capture of the pupil. So the centration in all these cases is much better, and majority of my patients, I can tell that majority of my patients are 6/6 next morning, though they improve over a period of time as far as cloudiness and clarity is there, but majority of patients are 6/6. I have a smile machine also in my center, so I've been using smile for last 7 years and this for last 4.5 years, and I find that in smile sometimes the visual recovery, it takes more than 2 weeks or up to 3 weeks. But in this particular machine, the recovery is much faster, and majority of my patient, as I said, 99%, I would say that's what my perception is, that 99% of these patients read 6/6 the very next day. And everything is very clear. The only difference between Professor Titial's surgery and mine is that lenticule he removed like he is a master surgeon, so he removed it very well. But I always wanted to do a little bit of irrigation of the interface, because irrigation takes away whatever debris is there and gives a much better quality vision the next day. Thank you very much.
Thank you, Dr. Bharti, for nicely explaining this advanced refractive technique and very beautiful videos. So we will now go ahead with the next talk by Dr. Raghav Malik, which is going to cover refractive surgery screening. While Dr. Raghav is setting up his slides, you've already been exposed to the various options that you have for refractive surgery, and now you have seen 2 variants of lenticule extraction. Now we'll go back to the basics as to how you should screen the patients, and then we will proceed further. And we are all going to try to shorten our talks a bit so that we can finish on time. Thank you, Dr. Raghav.
Thank you, sir.
Good afternoon, everyone. At the outset, thank you, Tityal sir and Praful sir, for this opportunity. I'm Dr. Raghav Malik. I will be speaking about briefly about screening in refractive surgery. So I feel this is the most important part of a surgery. Doing the surgery itself, yes, with experience you get better, but the most crucial part is finding the right patient. So the purpose is to find the right candidate, and most importantly, to reject the right one. Why? Because most patients, yes, 95% do very well and are very happy, but those 5%, the unhappy one and the one who go into a complication, or most importantly an ectasia, are the ones that will haunt your nights. Okay, so what eyes are actually predisposed to a post-LASIK ectasia? So the purpose of the screening, yes, is to find out the patients who might be unhappy, but most importantly what we are looking out is for patients who might go into an ectasia. So there are three categories of eyes that can go into an ectasia. First is that is a cornea that is already destined to go into ectasia. That is, an eye could develop into early signs of ectasia at any stage. You could do the surgery before those signs start. So that eye, which is destined to go into ectasia, could go into ectasia. Secondly, a pre-operatively weak but clinically stable cornea. That is a cornea that is borderline, and you treat that. And thirdly, a cornea which is absolutely normal, but we treat it beyond the limits. That eye can go into ectasia. So yes, I am going to describe briefly the type of history and what all can you have to look into to find that patient. History, very important. We look into the patient's general history, ocular history, medical history, multiple things we have to ask the patient. There are things we have to look out for with the patient on any medication for a chronic disease. Secondly, age. Yes, age is a very good cross-linker. Higher the age, the chance of ectasia decrease. So that is also one thing. Sex predilection. Yes, we know that women during pregnancy or post-pregnancy can go into an ectasia. So that is also very important. Occupational hazards. There are patients who are working in probably a mill or something where they have higher allergies, so they tend to rub their eyes more. So the chance of ectasia is higher in some occupations. Stability of refraction is very important, and also the expectation, what the patient is expecting from your procedure. You have to tell your patient, and you both have to be on the same page. There are some absolute health contraindications which Dr. Manpreet also discussed, mostly HIV and also autoimmune diseases, and also pregnancy and breastfeeding is something which we want to avoid. I'll briefly go into the diseases. Diabetes, yes, we want to avoid, because though diabetes is known to be a good cross-linker, that is the chance of complications or an ectasia decrease in diabetes, but we can have epithelial instability. So the patient might have different refraction at different time points. Active atopy we avoid. Epilepsy, because a patient can go into an epileptic attack during the procedure. That is very important. History of fainting and of course hepatitis B and C can be a potential risk to surgical staff. There are absolute ocular health conditions like diabetes, glaucoma, corneal thinning diseases, of course, we totally avoid. History of any ocular diseases, hepatic eye disease, Sjogren's, Fuchs, because we can have flap instability, and unstable refractive error is also something which we have to avoid. We'll also avoid dry eyes, blepharitis, nystagmus and squint because of the obvious visual outcome. So now ophthalmic examination will include tonometry to find the pressures, tear film assessment, anterior examination, posterior examination. We go into the photometry and also finding the refraction of the patient. The patient should have a stable refraction for at least 6 months, though practically those 6 months is not possible, because nowadays post-COVID, yes, the chances of a change in refraction are very high because of the increased near work. So nowadays practically, even if we do have 3 to 4 months of stable refraction, that is at least no more than a 0.5 change in a sphere and no more than 0.25 in cylinder, we can go ahead. Orbit configuration, why? Because we have to dock the patient, so the orbit should be stable and it should not be too deep. So this is the brief of the pentacam I'm going to show you to show which patient is the right patient. This is a general map of the pentacam showing the anterior and the anterior float and the posterior float, the axial curvature and the pachymetry map. So this is just a brief overview. I'll go into details, but yes, on the left you will have the patient identifiers which we have blocked out, and also the anterior and the posterior cornea and the pupil and the pachymetry. This is the Bellin's Ambrosio enhanced ectasia map showing the anterior and the posterior floats and the difference map. So basically what we're doing in these two maps is that we have compared the corneal surface with the basic general sphere, and we are seeing what areas are hotter or cooler. That is, the red colors are the hotter ones and the blues are the cooler ones. So we have the map here. If we have the red colors, that is the cornea is steeper, and the blue means the cornea is flatter. So this is against the general sphere, but if we have a basic or we have something that is customized to the patient, known as the best fit sphere, if we are comparing the cornea with the best fit sphere, we can have more subtle changes on the cornea. I'll discuss this later. So this is again the map that we saw on the bottom left, showing the value, that is the Q value of the pentagam and the quality of the pentagam. This is the K1 and the K2, that is the flat and the steep axis. The mean keratometry. This is showing the astigmatism. It should correspond with the patient's astigmatism, which is very important. Also the center of the pupil, center of the cornea, and the thinnest points, that is the pachymetry. So Km should be less than 48 diopters, and a difference between the Kmax and the K2 more than 1 diopter is a red flag for laser vision correction. This is the sagittal map showing this is the right eye, OD, the nasal and the temporal areas, the flat axis, the steep axis, and this is a bow tie pattern, which is the normal shape in a cornea. We want to look out for anything that is different from the symmetric bow tie. What we can see is we can see the K1, the K2, the mean K, and the Kmax, the corneal apex and the pupillary center. We have to recognize the patterns as I discussed. There could be inferior superior or superior inferior asymmetry. That is the case, that is the keratometry can be different in the superior and the inferior quadrants of that map. So this is a normal symmetric bow tie with the rule astigmatism, and this is symmetric against the rule. And this is an oblique astigmatism. Skewing of more than 30 degrees between the axis is something which we have to look out for. So this is again, you can see there is a symmetric bow tie, but there is skewing of the axis. You see this more than 22 is of course risky, and we have to look out for such eyes. Okay, now this is something, these are abnormal patterns which you can recognize. So the normal was the bow tie, but these are the abnormal patterns. You can see a junctional or a vertical D. You can see this, you can say you can also call it a joker face or a smiling face, showing this big red pattern. Anything red, always be wary of. It can be normal also, but yes, these are like a butterfly pattern, or we have a claw pattern which we can see a PMCD also. So this is the map, like I was telling you. If we look at the Bellin-Ambrosio map and we compare the cornea with a best fit sphere, that is the reference sphere. So the red areas are the red ones, that which is steeper, and the blue is the flatter areas. Okay, so this is very important. We have to look out for the center of the that is the center of the cornea, which is the thinnest point, and also what is the thinnest point of the cornea, which in a typical or a normal cornea should coincide. That is the center of the cornea and the thinnest point, because we know the cornea thins from the periphery towards the center. But in case if we have a difference or deviation, that is this is the center of the cornea and this is the thinnest location. If we have a deviation, that shows yes, there is some ectasia happening, because in the area of ectasia we have some thinning. So we need to look out for any deviation between the center of the cornea and the thinnest point of the cornea. Of course, if it is more, it should be normally less than 10 microns, but a more than 10 micron difference is something which we look out for. Again, in this case, an inferior dislocation, that is, this is the center point and this is the thinnest point. This difference shows that there is something going on in the cornea and there is some thinning. So these are the enhanced ectasia screening maps. Like I showed, this is the Bellin-Ambrosio enhanced ectasia. So if you see this map, this is the anterior float and the posterior float against a best reference sphere. So if we have something over here, that means yes, that there is subtle changes between the anterior and the posterior float. If this map is coming positive, that is still okay. But if we do have something on the posterior elevation, that shows early subclinical signs of ectasia. And these are some other measurements that we have, that is the CTSP, that is a corneal thickness spatial profile. I will come to that in the next slide, and the percentage thickness increase. So this map, this is the CTSP that shows the average of the thickness of the cornea along 22 imaginary circles, and the PTI, that is how the cornea is changing its thickness from the center to the periphery. We know for a fact thickens from the center to the periphery. If it goes within these two standard deviation, it's fine. But if it is below the standard deviation, that means there are certain chances of ectasia post-surgery. Now, what are the earliest signs we can detect? Of course, corneal biomechanics, Dr. Manpreet also spoke about. So basically, we just want to see how fast the cornea can rebound. If we make a puff of air on the cornea, how back it rebounds. So normally this elasticity is lost in a keratoconic or an ectatic eye. So we want to compare that with a normal map. So this is something which is the normal cornea, but if you see in the keratoconic eye, it goes much further. So elasticity of the cornea is lost and the cornea is weakened. So this is what we are comparing, a normal cornea and an abnormal cornea. So this is of course not one single test that we can confirm. This is a supplemental test to your keratometry and your topography. So there is something which we call the TBI. So this is the map that we get from the corneal biomechanics, and this is the map that we get from the pentacam. So they both give us a value. This is the corneal biomechanical index that we get from the biomechanics, and this is the bad D value which we get from the pentacam. When we put these two together, when we look at the topography and the weakness score of the cornea, we get a total biomechanical index which should be less than 0.3. So if you have a patient where you have a borderline topography and you supplementarily do one more scan, if we get a green figure, that means you are within the 3 standard deviation, and 97% you should be within the normal. I'll just wrap up my presentation now. This is some very subtle changes, epithelial mapping. Whenever we have an ectasia, we can have epithelial hyperplasia. So those areas where we can have very subtle changes of ectasia, we can see certain epithelial changes. If you see in this area, we have epithelial hyperplasia, and this is where we are looking for signs of ectasia. Again, Bowman's membrane loss or damage is a very early sign. With the spectral domain OCT, we can see any breaks in the Bowman's membrane. So we all fairly we know about the ectasia risk scoring system by Dr. Randleman. This just gives 5 points, which is not very relevant today, but still we should never avoid it. We're looking at the abnormal topography, lower residual bed thickness, young age, low preoperative cornea, and high myopia. If we score the patient basis these, and if the patient is in the low risk zone, we can proceed. If it's in the high risk zone, we can probably add an extra procedure. So on the horizon, we have definitely we have AI, that is artificial intelligence and machine learning. We are feeding our machines now with abnormal topographies and biomechanics, and once we have enough data, the machine can tell us before even us looking into the cornea whether this patient can go into ectasia or not. So that is something that is very exciting on the horizon. Thank you.
Thank you very much, Dr. Raghav. So very nice, beautifully explained all the steps for screening of patients, and also explained the principles of interpretation. So with that, we go ahead with the next lecture by Dr. Pratik Teotia, which is going to be on the topic of LASIK. So as you have seen, Manpreet had nicely shown you what are the various options. You have had exposure to smile technique, or another variation of lenticule extraction. So now you'll be getting the overview of LASIK surgery. Hello.
Thank you, ma'am. Good afternoon, everyone. The topic of my today's presentation is LASIK. So, LASIK stands for Laser Assisted In Situ Keratomyelitis, and it was Jos Bereker who first conceptualized it, but father of LASIK is Dr. AIIMS Palikaris, and who christened the term LASIK. So keratomyelitis means to shape the cornea, and in situ means in place. So LASIK stands for to reshape the cornea in place using laser. So what is excimer laser? So excimer laser stands for excited dimer. It refers to inert gas such as argon or xenon bound with a halogen such as fluorine or chloride. And the combination gives us diatomic gas halide, which is a temporary excited state. The excimer laser is a computer controlled ultraviolet beam of light that reshapes the cornea so light can focus directly on the retina, thereby reducing refractive errors. So in the laser cavity, argon fluoride gas is excited by 25,000 to 30,000 volt. The light discharge is the result of this excited dimer, argon fluoride, returning to its ground state from this state of excitation. So during decay, it emits ultraviolet rays of 193 nanometer wavelength, and which cause removal of the controlled amount of tissue with extreme precision. The picture shown here is a human hair which has been etched with excimer laser. The cuts which are given with excimer laser are extremely precise. So excimer laser remove corneal tissue by process known as photoablation. It is primarily a non-thermal process. So these are the pictures showing effects of thermal lasers and non-thermal lasers such as excimer. So in excimer there is very minimum or no collateral tissue damage compared to the thermal lasers in YAG and carbon dioxide lasers. So type of excimer laser procedures, they are surface ablation and LASIK. So surface ablation, we classify them into three types: PRK, LASIK and epi-LASIK. The basic difference is the flap. In LASIK, a flap is made which can vary from 90 to 180 micron. In surface ablation, there is no flap in PRK. There is epithelial flap in LASIK and epi-LASIK. So treat myopia, the central cornea must be made flatter. So this is done by removing tissue from the center. So while treating myopia, the flattest case should be considered. As told by previous speakers, each 1 diopter correction flattens the cornea by 0.75 diopter. So we should not end up with less than 34 diopter at the end of this surgery. In hyperopia, the central cornea must be made steeper. This is accomplished by directing the laser beam from towards to remove the tissue from the from around the central cornea. So while treating hyperopia, the steepest case should be considered, since each 1 diopter plus 1 diopter treatment will steepen the cornea by 1 diopter in average, and we should not end up with greater than 48 diopter at the end of the surgery. And to treat astigmatism, corneal tissue is removed in a precise elliptical pattern so that the cornea becomes spherical. So indications are highly motivated patients with reasonable expectations who understand potential risk and benefits. Myopia in the range of 1 to 12 diopter, hyperopia plus 1 to plus 6 diopter, and astigmatism up to plus minus 6 diopter can be corrected. Adequate corneal thickness should be present after ablation. So a residual stromal bed of 300 micron should be there. PTA should be less than 40%, and post-op corneal thickness should not be less than 410 micron. So indications and contraindications have been taken up by previous speakers. So coming to the procedure, I will show a small video. So this is a video of the LASIK. So after preparing the patients, first the microkeratome, first the marking is done on the cornea. So if you are a beginner, this is one of the crucial steps, because in LASIK we know that the flap related complications can happen, such as free cap, and this marking will come as a lifesaver in case such kind of complication happen. So corneal marking should be done at the periphery so that you can see the margins of the flap, and these markings also helps in aligning the flap at the end of the surgery. So this is the suction ring being applied, and then the microkeratome pass is made. The instrument in this video I am using is microkeratome from the Moria. So no financial interest. So this was the instrument available there. Then the flap is lifted, and then the excimer laser is fired. So at the end of the surgery, the flap is reposited back after cleaning the stromal bed with BSS, and then with LASIK wax spawn you wipe out the excess fluid from underneath the flap. So you can see that the markings are aligning with the periphery so that your flap is in accurate position. Now at the end we put a antibiotic drop. So this is the end of the surgery. Femto-LASIK or interlace, here the flap is created with the femtosecond laser. So it is very precise flap thickness, and it gives precise flap thickness, diameter, and regularity. There is minimal chance of human error, and there are very less chances of flap-related complications. So femtosecond laser creates photo disruption with the solid-state laser with wavelength of 1053 nanometer. It needs lower vacuum. In microkeratome LASIK, the vacuum rises up to 65 mm of Hg. Here it's around 35 mm of Hg. So very short pulse with spot size of 3 micron give high precision cutting, and you can make hinge either superior or nasal with the femtosecond laser, and you can change the size of the flap also with the settings which are provided with the machines. So it can make flaps as thin as 90 to 100 micron. This is known as sub-Bowman's keratomalysis. The advantage of flaps made with femtosecond laser are they give planar flaps, while the traditional microkeratome used to give meniscus flaps which are thicker in the periphery and thinner in the center. So this is a small video of femtosecond LASIK. So here the suction ring is applied. Once the vacuum is achieved, then the cone which is fitted into the machine, it is applanated on the cornea into the suction ring, and then the femtosecond laser pass is made. So once the procedure is over, then we remove the suction ring and the cone, and then we raise the flap with the flap elevator. The dissection here is quite smooth. So once the laser is fired, then the same procedure is repeated. Post-op management is topical antibiotic and corticosteroid along with artificial tears, and patient is advised to avoid water inside the eyes, wear protective gear in any contact sports, avoid eye rubbing to prevent dislocation of the flap, and in case any enhancement or retreatment is planned, it should be after 3 to 6 months later after adequate stabilization of refractive error. So there are some risks also with this surgery, such as overcorrection or undercorrection, with a possible need for a retreatment, reduced contrast vision, poor night vision, glare, halos, starburst and ghosting of images, corneal infection, light sensitivity, dry eyes, flap complication, loss of vision, and regression of initial surgical effects. So not all procedures are free of risk. Some intraoperative and postoperative complications can happen. So intraoperative complications such as free flap, loss of corneal flap, perforated or thin flap, corneal perforation, bleeding from neovascularized cornea following pannus, and decentered flap or large flap. Postoperative following surgical procedures such as displaced flap, corneal infection, and DLK, also known as sands of Sahara, and regression. Thank you for your patient hearing.
Thank you very much, Dr. Tiota. That has nicely covered the topic of LASIK. So I'll go ahead and give a talk on phakic intraocular lenses. With that, we will be coming to the end of this refractive surgery session. So as Dr. Manpreet explained earlier, patients coming for refractive surgery, they are wanting to get spectacle-free or spectacle independence. As healthcare professionals and ophthalmologists, it's our duty to give them the best option, but also be very careful in our case selection and suggestions as to which is the best optimal procedure for them. And over and above what you have learned before, one point I would also like to add is it's important to know if the patient is wearing contact lenses. So if a patient is wearing contact lenses, then they should be advised to discontinue the wear before they come for their clinical evaluation, and ideally recommended is 2 weeks if they're wearing soft contact lenses. Now coming to phakic intraocular lens, as you can see in the picture, that is your natural crystalline lens, there's your cornea, and then you can see that transparent structure which is in the posterior chamber just anterior to the lens, that is your phakic intraocular lens. So what are they? They are implantable lenses used to correct refractive errors while preserving the natural lens of the eye. There are specific indications and patient selection. So the preoperative assessment, informed consent, counseling, surgical techniques and implantation, and postoperative care and follow-up are what I'm going to cover very briefly for you. So largely it is not a procedure of first choice because it is an intraocular procedure. So one would, apart from the general workup, usually it is offered to patients who are not good candidates for cornea-based procedures. That is the general trend for the phakic intraocular lenses. And do they have any other advantage? They do, because they can take you beyond a limit. As Dr. Raghav told you, the third risk of ectasia is if you do too much correction on a healthy cornea. And phakic intraocular lenses gives you that option of providing the benefit of spectacle-free vision for a patient who seeks it. Lot of patients do come for surgery for professional purposes, and as of now, lot of those professions do not allow phakic intraocular lens, such as railways, the army, air force, and so on. But they may be coming for other reasons, such as if they are newsreaders or they are, have a public profile or on television and other media. Then phakic intraocular lenses can be beneficial for them professionally as well. Lens-based procedures can also be including refractive lens exchange. This is something that we offer patients who are coming little later on, such as maybe 38, 39 or 40-year-old. And then bioptics is sometimes you may offer a combination, that is an ICL, as well as top it up with a cornea-based procedure. So these are the standard general FDA approved limits, and as you can see, for phakic IOLs you can go up to -20 diopters, and then there is an Indian company which goes even beyond 20 diopters for refractive correction, and hyperopia also, it offers a good option. And of course the other ranges as well. So the screening parameters have already been gone through, and when you go through all the steps, a patient who would have appeared suitable for a cornea-based procedure may turn out to be not suitable, and then you go for phakic IOLs. And so largely they are for patients who have a contraindication for cornea-based procedures. And the technology and the surgery has improved so much that nowadays we don't have any hesitation in offering it to these patients, even sometimes for lower refractive errors. Can anybody tell me which case of a slightly lower refractive error you may consider a phakic IOL? Would you like to guess? Thinking about what Dr. Raghav said. So there may be a slightly borderline abnormal cornea, like a patient who is sort of stabilized with a formfrous keratoconus and is stable. The refractive error is stable. So there you will not go for a cornea-based procedure, but you could offer a phakic IOL for that kind of a patient as well. And these are the various parameters that you need to look out for. And specifically, we are doing extra, the specular count and the AC depth. These are the two extra parameters that we measure. And are further sort of cutoffs for safety. So these are the standard cutoff parameters. Now talking about the phakic IOL types, largely nowadays we have all shifted to the posterior chamber lenses. Earlier there were angle supported lenses and iris fixated lenses, but in modern day with the availability of very good posterior chamber lenses, that is our procedure of choice. So this is the one example. I have no financial interest. This is it is called an ICL, an implantable Collamer lens. And this also has undergone several iterations. The V4 model is what is now used today. It has a central hole called an aqua port. So with this design, you do not require to do a PI preoperatively, except if the patient is hyperopic. The hyperopic one doesn't have the central hole, and then you have to do a PI. So in the interest of time, I won't take you through the various options. I'll just take you to the surgical video, because otherwise things are very much similar to what you've seen before about the workup, etc. Yeah. So this is an example of a case, 26-year-old lady who had come to RP Center in 2021. She had used spectacles for 6 years. Her refraction was stable. She had no history of contact lens use, and she wanted refractive surgery for a cosmetic reason. She had no systemic illness. As you can see, this is what I was illustrating. So the higher refractive powers, no problem. But this is like a lower refractive power. This is a power that we would normally have liked to do LASIK, Contura vision, a cornea-based procedure. However, she did have some borderline papillae, some corneal thinning and ectasia, and the power had been stable. These are example of her maps. The Kmax is beyond the limit of 47. She has a thinner cornea. So she's definitely not suitable for a cornea-based procedure. Her D values are also high. And so we had the option of telling her nothing versus the one, and as you can see, the bad is also showing a clearly unstable cornea, kind of a formfrust keratoconus, and similarly even her TBI is way off in the red, as you can see below. So therefore the patient was a good candidate for a phakic IOL. We have done the specular count. Her AC depth was adequate, and she required a toric ICL. I'll quickly show you the steps of the surgery. So first, we usually prefer to do the surgery under topical anesthesia unless the patient is very cooperative. We clean and drape the patient, but we don't actually put the opsite till we first load the lens. This is the lens cartridge. It is first primed with BSS and then filled with a dispersive viscoelastic. After that, the lens is gently loaded. We have to be very careful about the orientation of the lens. It's very delicate. So the anterior leading haptic we're going to have a little dimple on the right, and the trailing haptic on the left will have the dimple. That is the orientation. It is loaded, and then it's put onto the plunger. So the lens is now ready. Then we put the opsite and drape the patient, put the speculum, and we first make the marking as to the alignment that we want. The pupil has to be dilated. We make 2 side ports. Be very careful with the entry, because you have to talk to the patient, make sure he doesn't suddenly move, make a jerky movement, because you do not want to hit the lens. And you make a 3.2 millimeter side port. You inject dispersive viscoelastic in the eye, not to overfill it too much, because the eye is too rigid, then the soft lens will not be able to open inside. So just enough dispersive viscoelastic, and then again when injecting it, be very careful about the orientation so it doesn't flip over. And then it is gently tucked into place with the haptics being put behind the iris. And then it is aligned according to your marks, because in this particular case it was toric. And then after this, we will remove the viscoelastic from the eye and then put topical anesthetic as well as antibiotics. Sorry, topical antibiotic and steroid, and then just put an eye pad, which they will open after 2 hours. And then we do the other eye after 2 hours in a different OT, different table, totally different set, and a different surgeon. Post-operative care is topical antibiotics and steroids. Sometimes you can give a short cycloplegic like tropicamide HS for 3 days, not always necessary. And other precautions, which are exactly what were mentioned before: no rubbing and no tap water in the eyes. So with that, I'll stop here, and thank you for your patient listening. And sorry for overshooting the time a bit. Okay, thank you.
So with that, we conclude our session on refractive surgery. I now welcome the next session. Dr. Lalit Verma sir is already here for the retina session. Yeah.
Let's go, Vijay. Thank you so much. Bye-bye.
Good evening, everyone. It's dot 4 o'clock and half an hour behind schedule. We will try to cover up, but timing is very important, because I think in all the scientific forums, one thing is that timing is very significant. And this those program was started long time back. Its history, I hope people know. We started long time back, and I was the person who started those in DOS, and it's meant to be a teaching program, and it has been distorted slightly, primarily because this is more of lecture baji going on rather than the teaching. Because teaching concept was that because teaching takes time. Teaching is not a 8 minutes job or 10 minutes job that you put slides here, vomit whatever, and it's not a unilateral exercise. It has to be a interactive session. But somehow the future secretaries of DOS they have converted into it's more like a conference rather than a teaching program. But in any case, we will. There are 9 talks of 10 minutes each, and we have 1 in 20 minutes. So I'll request all the speakers to make it as simple as possible. Do not try to show off too much that so much heroics is possible, because our target is totally different. Target is not specialist. Target is budding ophthalmologists or people who want to learn. So with this few words, and I have with me my old friend Dr. Rajpal here, and we have Alkesh Chaudhary. Shaurya is coming or busy somewhere? In any case, we will start. And first 3 talks are on diabetes. We will not have any question answer amongst ourselves, but if anybody of you wants to ask any question, you are more than welcome. We will encourage questions from the audience rather than that I asking Rajpal or Alkesh or somebody. We will not ask mutual question, but you should ask in case you have any doubt. You can stop anytime and you can ask, what is there in this, diabetic retinopathy or whatever. Because I'll be very happy in case all of you go back richer by at least one or two aspects of any disease. That is the whole concept. So we begin with Dr. Vinay. Vinay is, chairman of Synergy Group of Eye Hospitals, doing very, very well in practice. He was with us, RP Center, but he has made a big name for himself. And he was one of the pioneers of small incision vitreous surgery, and does a fantastic job. So Vinay, you will have to tell the audience about diabetic retinopathy, primarily classification.
Thank you, sir.
Pathology is by and large a theoretical topic. So
yeah.
Let us be more of classification than.
So thank you, sir. I think there's a lot of bias in what you just now told about me, the teacher's bias. So it brings me memories of being here as a JR, presenting the cases in front of the teachers and the colleagues. And now it's the other side of the spectrum that I'm here to hopefully teach you guys. And I don't know whether I'm the best suited person to be taking this talk on pathogenesis, because we in practice are doing more of practical stuff and less of the basic science research. So if there are any questions, feel free to ask me. The slides were provided to me by Praful because it was just a last minute thing that I got it. So thank you for that. And if there are any questions, please feel free to ask. If not me, my other more learned colleagues can possibly answer those questions for you. So coming to diabetic retinopathy, so we all know diabetes mellitus is the big problem of the world, and especially in India, we are getting lots of patients with diabetes. And it's a multi-system disorder which influences each and every organ of your body, right? Now, classification, it's a IDDM or NIDDM, insulin dependent or non-insulin dependent, type 1 and type 2. And sometimes there can be secondary causes also. So the factors which are affecting diabetic retinopathy, like any disease, it is multifactorial. And most important is the hyperglycemia levels and the duration of diabetes. So these are very, very important factors. Besides that, you can have other factors like if you have a sudden control of glycemia, that can also sometimes worsen it. So therefore, you have to be careful when you are controlling a badly controlled diabetes. And then, of course, hypertension has to be controlled during pregnancy. It can get worsened, nephropathy, and all those things that you are aware about. So in pathogenesis, there can be 2 aspects to it. One is anatomical changes that you have, and second is the biochemical changes. So in the slides provided to me by Praful, there was a lot of information about the biochemical changes also. But since I don't understand that too much, I have removed those slides from here. Right? So I think from the practical point of view, the biochemical changes are important if you are looking at a research angle to it. Like, for example, in the sorbitol pathway, you want to work towards something to find out some drugs to control that, to decrease the effects of diabetes. So yes, that is important for you people at a beginner, at your learning stage, that you should be aware about it. And if someone wants to go into research side, it will be very useful for you. But since I'm in practice, I'm not dealing with it. So it kind of went above me. I didn't want to put something which I'm not comfortable with giving answers to, so I've just removed those slides. Anatomical parts will be dealing with that. So in biochemical mechanisms, these are the various pathways and theories that have been recommended. I mean, of course, we still don't have an answer to any of these. There was a lot of talk about aldose reductase inhibitors and all those things, but nothing kind of came out to the practical use. As of now, the pharmacological means that we have is anti-VEGFs that we all aware of. The other things are still research under progress, but I'm sure sometime we are going to find some of those pathways where if you block it, you are going to possibly decrease the effects of diabetes on all the organ systems of the body. So that is the future research that hopefully some answers will come our way. Now coming to the anatomical changes that you have in a diabetic, you can have loss of pericytes, capillary basement membrane thickening, microaneurysms, capillary acellularity, breakdown of the blood-retinal barrier, and hard exudates. So let's see how it looks like. So in the loss of pericytes, basically it causes more of leakages from the smaller blood vessels, and also it causes the bulging because that the strength of the capillaries becomes weaker, so therefore you can have aneurysms formations there. Now capillary basement membrane can get thickened, and that can lead to more blockages of the vessels. So basically there are two aspects that are happening in pathogenesis. One aspect is more of leakages happening from the blood vessels. Now those leakages lead to the NPDR changes in the eye, where you're getting the leakages, swelling, some hemorrhages. The other aspect is the ischemia and blockages. That leads to the PDR arm of the diabetic retinopathy. That is happening because of the basement membrane thickening, or because of endothelial changes, or because of platelet adhesions or RBC changes. So you can see the capillary basement thickening that can happen in these diabetic capillaries. These are the various types of microaneurysms that you can have, the various structures, not very important in the clinical sense, but yeah, those are the various kinds of images that you can see. The capillaries have the decreased number of cells, so that again shows that it's a microangiopathy. There's a breakdown of the blood-retinal barrier, and here again VEGF possibly plays a role because it increases the leakages, and that can lead to edema. And you can see the hard exudates. Now these are the chronic deposition of the lipid proteins, lipid out there. It's mainly the outer plexiform layer is involved, and you can see these yellowish kind of very distinct margin kind of lesions that are there. So that basically means there are abnormally permeable vessels or microaneurysms which are leaking the fluid from there. Now in case of a PDR, because of the VEGF that is there, these new vessels can branch out. The whole concept, if there's this ischemia that is happening to the organ, the body tries to form the new vessels. But these new vessels that are being formed are not actually the useful new vessels because they're very fragile. And these fragile new vessels form the NVEs or the NVDs. So this is a new vascularization that can take place. Now this is a classical Kansky textbook photograph that all of us have seen. And single photo describes beautifully what all can happen there. So there's one arm which is the leakage arm, which happens because of loss of pericytes and more leakages in the blood vessels, causing the NPDR aspect of the changes of the diabetic retinopathy. The other arm is the occlusion, where because of basement membrane thickening, endothelial cell damage, RBC changes or platelet stickiness, these causes the ischemia, and that leads to proliferation of new blood vessels and all the complications of PDR along with that. Now microangiopathy, again the same thing. The occlusion is because of the basement membrane, endothelial damage, RBC and platelets. That causes ischemia, causes increase of VEGF levels, and that causes the AV shunts of IRMA, that is intraretinal microvascular anomalies, or neovascularizations in form of new vessels at the disc, elsewhere, or at the level of iris. And the microvascular leakages happen because of loss of pericytes, and that causes distension of the capillary wall, breakdown of the blood-retinal barrier, and that leads to microaneurysms, retinal hemorrhages, diffuse retinal edema, and then also hard exudate. So the left side is the PDR element of the changes, and the right side is the NPDR element part of the changes. Now coming to how they look like, I'm sure you people have seen these slides, these lesions already. So microaneurysms are the earliest sign of diabetic retinopathy, and you may pick up microaneurysms, very small ones on FAs, but clinically you can pick up if they are 30 micron or more in size, right? So these are small localized outpouchings that are there, and they happen in the inner capillary plexus, that is the inner nuclear layer, right? So, and then you can have intraretinal hemorrhages. Now there are two types of hemorrhages that you can get. One is a superficial and one is deep. The superficial one is at the level of nerve fiber layer, so you will have a flame-shaped hemorrhages, whereas the deep one is at the deeper layer, therefore you can see a dot and blot hemorrhage, that is the inner nuclear layer or the outer plexiform layer. So, sorry. So superficial ones are the flame shaped. So they follow the pattern of the nerve fiber layer, therefore it is in a flame shaped thing. And they are happening from the large superficial precapillary arterioles. And the deeper ones are dot and blot hemorrhages, which is at the outer plexiform and inner nuclear layer. And then you can get hard exudates. Now, one important thing about hard exudates are often you will find a small leaking aneurysms in the center of the succinate ring. So that is an important criteria, that if you are getting a ring of exudates, try to look at the center. You might find a leaking aneurysms out there on FA. And these are the cases where a focal laser might help treat these cases. So earlier we have been taught, when we were learning, and I'll be coming to the classifications later, that we were taught about doing the focal laser and the grid laser and all those things for diabetic macular edemas. But nowadays, with the onset of anti-VEGFs, no one is doing any grid laser anymore. So you're doing either anti-VEGFs or you're doing focal laser. But focal lasers still have a role for the extrafoveal kind of a leaking points, where if you have one of few leaking points, it's a very good result if you can pinpoint the leaking aneurysms and do a focal laser there. So when you have a succinate ring, try to look for a leaking point in the center of the succinate ring, and you will probably find many times some leaking vessels there, leaking aneurysms there. Now, soft exudates are at the level of nerve fiber layer, and they are more fuzzy looking. They're called, because it's not as well defined as a hard exudate, it's a more fuzzy looking kind of a thing. So if you can compare the hard exudates, it is very, very well defined kind of a structure, right? But when you see the soft exudate, they're very fuzzy kind of a thing. Therefore, they're called soft versus hard, right? So it's not that it is softer or harder, it's just that it appears more soft and more kind of a wavy kind of indistinct margins. So they are basically neuronal debris, and they are small fluffy whitish lesions that are at the superficial level. Now, you may also find some venous changes also. So one very good trick of looking at the fundus is, of course, you should do a very good direct ophthalmoscopy, 90D examination, and indirect ophthalmoscopy. But many times you may miss out these minor changes. Since we have a fundus camera with us, not a bad idea to take a few photos of these patients and then examine these photos at leisure. You will definitely pick up many more points which you would miss out in a direct ophthalmoscopy or indirect ophthalmoscopy or a 90D, because at that time the patient is moving his eyes and doing all those kind of things. But when you evaluate a photo, it gives you a lot more information. So make it a habit, whichever kind of a fundus camera you have at your center, pick out a few photos and examine these patients in details, and you will discover many more things, right? So here you can see that they are focal areas of venous dilatations. You can have a loop of vein also that you can see, and these areas normally would have some capillary non-perfusion in these areas. So these are all compensatory mechanisms of the body to try to take care of ischemia there. Now you can have a generalized dilatation, tortuosity or looping. So various kinds of changes that you can find in the vessels. Now AIIMS are again arteriovenular shunts that are there, and they run from the arterioles to the venules. Now they are different from NVEs because they don't leak on FA the way the NVEs would be leaking, right? But they are at the earlier stage of ischemia compared to NVE. Now NVD, again, you know, those are new vessels at the disc. They are quite easy to pick up and not very difficult to miss out. And then you can have NVE, that is new vessels elsewhere, that is at areas which is other than the disc. And then of course at the later stage, when there is new vascular formation, there's a fibrovascular proliferation taking place. So when the vessels part are decreasing, but the fibrous part is still pulling a traction, it can cause a tractional retinal detachment also. So TRD per se can be there as a late stage of PDR. Now TRD, if you have a TRD which is in the periphery not causing any problem, you would probably just observe these patients, do the laser in the other areas. But if the TRD is threatening macula or it is involving macula, then it might be a reason for doing a surgery for them. So you have to make a note of TRD, mark out where all the TRD is there so that you can find the progression of the TRD, whether it is happening or not. And a good idea is to take a photo, if you can take a photo of the TRD and have a sequential photograph to see whether progression is happening or not. Now vitreous hemorrhage, of course, when the things go beyond that, if the blood vessels which are very fragile, they rupture, you may have a vitreous hemorrhage also. So now coming to the diabetic retinopathy classification. So we'll start with the earlier classification that we used to read, that is about the ETDRS. If you remember, ETDRS is early treatment of diabetic retinopathy study. That was there before the injections came in, and this was primarily to do with the lasers, when the treatment was a laser for all the macular edema. So what it divided the diabetic retinopathies into two parts, NPDR and PDR. NPDR is non-proliferative diabetic retinopathy, that is a leakage arm, and proliferative diabetic retinopathy is the PDR, which is the ischemic and the neovascular form. So NPDR can be mild, that means there's at least one microaneurysm, because that's the earliest change that you see in the diabetic retinopathy. Now moderate is somewhere between mild and severe NPDR, so as per the definition you will have some hemorrhages and you may have some cotton wool spots or venous bleeding. Now severe NPDR had a 4-to-1 rule. So 4-to-1 is basically 4 quadrants of severe retinal hemorrhages, or 2 quadrants of venous bleeding, or 1 quadrant of IRMA. So if you have one of these, then it is severe NPDR, and if you have 2 of these, then it is very severe NPDR. Right? So 4-to-1 rule is a very common question that used to be asked during our time. I don't know nowadays whether it is asked in the exams or not. So this is one thing you should remember. So 4 quadrants of hemorrhages, or 2 quadrants of IRMA, or 2 quadrants of venous bleeding, or 1 quadrant of IRMA. And IRMA is still at the NPDR stage, mind you. Now in PDR, any neovascularization is called as a PDR. Now there was a definition of high risk PDR that was there in DRS study, in which basically means that whenever there's an NVD, which is 1/4 to 1/3 of a disc area, that was a high risk PDR. High risk means there is a high risk of severe vision loss. So in that study of DRS, they basically were trying to see the effect of a laser. So they divided into high risk and non-high risk PDR. Any NVD with any vitreous or preretinal hemorrhage is again high risk PDR, or any NV which is more than half disc area with vitreous or panretinal hemorrhage. But nowadays we often don't go into high risk PDR. Any PDR we would like to treat. So this is of very less practical value actually. Now in the newer international classification, this is a much simpler thing. No retinopathy, there are no abnormalities. Mild NPDR has only microaneurysms. Moderate is somewhere between mild and severe. And severe is again, anything that is having that 4-to-1 rule, that again same thing applies. And proliferative, if you have either of the neovascularization, either in the disc or NV, and with or without the vitreous hemorrhage. Now coming to clinically significant macular edema. So now first we differentiated what are the different types of diabetic retinopathy. Now we're talking about macular edema. Now in macular edema, again in ETDRS, they defined as clinically significant and non-clinically significant. So clinically significant, basically the definition was any thickening of the retina within 500 microns of the center of the macula, or any hard exudates within 500 microns with adjacent thickening, or any zone of retinal thickening which is more than 1 disc area, some part of which is within 1 disc diameter from the center of macula. So just to, again, a favorite Kansky diagram. So in number 1, you can see that within 500 micron of the center of fovea, there is a thickening that is there. In the second, you see there is a hard exudate within 500 micron, and there's an adjacent thickening that is there. That is second category. And third, you can see that there is a large area of retinal thickening, which is more than 1 disc area in size, which is within 1 disc diameter from the center of the fovea. So this is the definition of clinically significant macular edema. And this was the NPDR study which showed that in case of CSME, there is a value in doing a focal laser or a grid laser. That's the study was all about. But now again, we are changed that thing, made it simpler for you guys. So it's simple that if you have got the center of the fovea is involved, then it is severe macular edema. If it is very close to the center, it is moderate. If it is further away from the center, then it is mild. So that's a very simple thing, and it's clinically more useful. And now what is even more important now on OCT, what we see that if it is involving the central 1 millimeter of the foveal zone, then it is center involving macular edema. And if it is not involving the central 1 millimeter zone, then it is non-center involving macular edema. So most of the non-central involving macular edema would have normally good visual acuity also. So this is about the classification. Any questions if you have, I'll be happy to answer.
So thanks Vinay for elaborating in 10-15 minutes about which normally takes so many lectures. Any question? Anybody? You should stand up and ask. But but what I would wish that you should remember is the last 4 slides are very, very significant about classification. Those 2 slides are important. No longer people are asking about clinically significant macular edema. Today in the era of OCT and photography, we just talk of international classification only, center involving, non-center involving. and diabetic retinopathy classification, that 4-to-1 rule. Because why it is important is after severe NPDR, things take a turn for the worse. So nobody should miss that severe NPDR. You see, mild, moderate, we still have to follow up. But once the disease approaches severe NPDR, I think that is the time when everybody tentacles are high and you have to guard the patient that now you should start acting. So any question from anybody? Otherwise we go to the next.
Thank you, sir.
भाई प्लीज कुछ पूछो भाई आप लोग सब. Next we'll have
Dr.
Vinod.
Yeah, Dr. Vinod, PDR.
Yeah. So Vinod will consider it primarily on PDR. You see, like when I was talking that diabetic retinopathy is a microangiopathy. It involves smaller vessels. Vis-a-vis, we have ES disease, vascular block, or base sets which involve larger vessels. So diabetic retinopathy involves smaller vessels. Therefore, not a microangiopathy. So, and he said one is a ischemic process, one is a edematous process. So ischemic process ultimately leads to the sequelae of PDR are more dangerous. So PDR, although it's a very severe disease, sometimes it can have 6/6 vision also. So although presence of NVD itself reflects that more than 25-30% retina is ischemic. So it's very important to not to miss PDR. A cursory examinations, as soon as you are ready, you let me know.
Yes, yes. So good evening, everyone. At the outset, I would like to thank the Delhi Ophthalmological Society for giving me this opportunity to interact with you. So I've been asked to talk predominantly about proliferative diabetic retinopathy, and I'll be restricting myself to that only. So as Dr. Grodia discussed, and as you all know, PDR, which I'll be using the terminology, not proliferative diabetic retinopathy, is the late stage of diabetic retinopathy, and it is the most common cause of severe vision loss in patients with diabetic retinopathy. Now, as per older studies, a larger number of patients in type 1 diabetes as compared to type 2 diabetes go on to develop PDR after say 15 years of onset. But because of better management of you can say diabetic retinopathy, the incidence of PDR has reduced. This is as per textbooks, but in my own experience, the number of PDRs which we experience nowadays is much higher than actually we used to say 5 years back. One reason maybe is just because the sheer number of diabetic population is so large. So as we know, in diabetes as compared to some of the other vasculitis, the ischemia tends to be panretinal. Whole of the retina is involved. So when the patient has enough of capillary non-perfusion, patient go on to develop neovascularization. If it is at the disc or within 1 disc diameter around it, it is called neovascularization of the disc. Anything outside that area is known as neovascularization elsewhere, as you can see over here. So probably this one would fall in the category of NVD, but anything else, all others will fall in the category of neovascularization elsewhere, and subsequently it leads to complications. Now, few things you must understand in PDR is, because these retinal neovascularization which happens, it initially happens on the surface of the retina, and as Dr. Grodia explained, what happens is these vessels are fragile vessels. They are new vessels. They tend to die on their own, and once they die out on their own, it leads to fibrosis. Okay, so that is the cycle which keeps on going. There is new vessels, they die, it leads to fibrosis. At a certain point of time, these new vessels grow into the vitreous cavity, and thereby it leads to firm attachment of the vitreous and the retina. So at this point, when the fibrosis occurs, this vitreous contracts, this lifts up the retina, leading to tractional retinal detachment initially, and subsequently a combined retinal detachment. Now, so this vicious cycle keeps on going in most of the diabetics, and most of the diabetics do end up in tractional or combined RDs, except a few fortunate few where this cycle dies out spontaneously and patients end up with quiescent proliferative diabetic retinopathy. Now, these vessels are fragile, they bleed, leading to vitreous hemorrhage. Vitreous hemorrhage can be intragel, that is called vitreous hemorrhage, or in the subhyaloid space, retrohyaloid space, when it is called subhyaloid hemorrhage. When the vitreous contracts, it leads to tractional retinal detachment initially, and subsequently when the traction is too much for the strength of the retina, there is a break in the retina leading to a combined retinal detachment. And subsequently, if it is not treated, the ischemia progresses, neovascularization progresses go on to involve iris, and subsequently can lead to neovascularization, neovascular glaucoma as well. So these are few photographs just to show when the vessels happen on the disc. It is called NVD. Most of the NVs are usually outside the arcades, but at times they can be inside the arcade close to the macula. They die out leading to fibrosis. This is how it looks like initially when there is initial fibrosis. These blood vessels can bleed leading to intragel hemorrhages when you don't see much of the fundus if it is extensive, or it can lead to subhyaloid hemorrhage. And remember, they are not always red. Once the blood gets altered, it can lead to white colored hemorrhages, or you can say altered blood is there. So do not confuse. This fibrous tissue keeps on growing and it can lead to tractional retinal detachment in the macula or elsewhere in the fundus, and subsequently it leads to a combined retinal detachment. We have already read about high risk PDR. The only significance is while in a patient with non-high risk PDR, you can wait for some time to do a pen retinal photocoagulation. In high risk PDR, you go on to do PRP at the earliest. Now, diagnosis of proliferative diabetic retinopathy is predominantly clinical. We do not need angiography for making a diagnosis of PDR. And these neovascularizations, if they are subtle, they can be better seen with red-free photographs, as I'll be showing you. One very characteristic feature of PDR is sometimes the retina is absolutely, you can say, featureless. There are no hemorrhages, there are no hard exudates, no soft exudates. This is because of the extensive ischemia. There's no leakage happening, and that is why it is called as featureless retina. So when you have a patient, say long-standing RD, and you have a very featureless kind of retina, and if you see a small vessel somewhere, small new vessel, do not hesitate to do a angiography to confirm your diagnosis. You may be dealing with a case of proliferative diabetic retinopathy. On the other hand, if there are hemorrhages which are subhyaloid or intragel, it is very easy to make a diagnosis of proliferative diabetic retinopathy. You have to distinguish NVs from AIIMS. One thing already told was while neovascularization leaks on fluorescein angiographies, on clinical examination, remember, while NVs are fine crisscross vessels, the AIIMS never cross each other. And second major thing is that AIIMS never cross major vessels while NVs cross major vessels. Fluorescein angiography, as I mentioned, is not required for clinical diagnosis, but if you have doubt about subtle NVs, you can go on to do a fluorescein angiography. Not only it shows you the extent of capillary non-perfusion, also it tells about the status of the macula in terms of leakage and macular ischemia. Nowadays, studies have shown that OCTA is as good as fluorescein angiography, but I personally feel that peripheral NVs can be missed because sometimes we may not be able to image as far peripheral retina as we can do with fluorescein angiography. Another disadvantage of OCTA as compared to FFA in patients with diabetic retinopathy is that you cannot assess leakage on OCTA. So these are few examples. You can see there is a nice large NV, which NVD certain part and some part falls outside the 1 disc diameter. So NVD NV which is there, which is very nicely seen on, you can say, infrared image. So it is a kind of red-free image, but it is taken on SLO, so it gives you better resolution. You can see the neovascularization better here. This is a routine red-free photograph, and you can see still it is better, neovascularization is better seen than color photograph, but not as good as SLO image. And this is a OCTA image. Because of the contrast, anyone can appreciate the neovascularization here. So another example, you can see this is a patient with PDR. There are multiple NVs Just to give you an example, nowadays we do wide field angiography. So this is roughly around 55-degree field. So this is around 100-degree field. You can see, we can see into the mid periphery of the retina. This is a octa image of the same patient, which by and large is similar to the 50-degree FA. If you see, you can see the NVs which are there corresponding. So octa and FFA are virtually similar, just that with FFA, with ultra wide field angiography, now you can image the periphery as well. OCT is very useful. It will tell you the cross section, it will give you the cross sectional images of the retina and all the changes which are happening in the macula. So this is the other eye of the same patient. Again, you can see fluorescein angiography. It matches with octa. This is just to show you, this is black negative image of fluorescein angiography, and again you can see that the similar changes can be seen, and if someone presents you with a similar image, you should not get confused. Again, OCT is very, very useful in such patients. A word about ultra wide field fluorescein angiography. So there are two patients. If you see, ultra wide field angiography gives you a wider view of the retina. Almost 80-90% of the retina can be imaged. So there are two types of retinopathy. If you see here, one is where is posterior, where there is predominantly posterior involvement, and other is where the whole of the retina is involved. So this is what is called predominantly peripheral lesions, and when you have PPLs, there is higher incidence or higher risk of progression to higher grades of retinopathy. And this is again an image just to show you that how beautifully ultra wide field angiography can show you large areas of capillary non-perfusion. OCT, I already told you, is very useful for seeing the concurrent macular affections, whether there is any tractional component. It is useful to know the extent and associations of TRD in the form of hose, etc. It can also be used to distinguish the planes between membrane and retina. Ultrasound we usually do when the media is hazy either due to cataract or vitreous hemorrhage to ascertain the status of PVD and retina. So just to show again few images, you can see a large tractional retinal detachment. On OCT, you can see where all vitreous is attached. It has cystoid macular edema, and over here you can see there is vitreous chysis with some intragel hemorrhage. So multiple things can be seen on OCT, even in patients with PDR, apart from macular edema. Another patient, so if you see the upper diagram, you can see hardly any changes of diabetic retinopathy, but you look at the OCT, you can see dots in the subhyaloid area signifies that this patient had a vitreous hemorrhage, and from the OCT only you can make a diagnosis of proliferative diabetic retinopathy. Another patient with TRD showing how thick the posterior hyaloid can get, which is causing traction onto the retina. Once you have a case of simple PDR, you can go ahead with penretinal photocoagulation. If there is associated macular edema, we can use prior anti-VEGFs so that edema does not worsen after PRP. Anti-VEGFs also reduce the chances of bleed, recurrent vitreous bleeds after PRP. And as I mentioned, always treat macula first and then go on to do PRP. Nowadays we have multi-spot lasers where you can give spots in the groups of say 4, 6, 9, 15 and 25. So one click will give you 25 spots. You can see they are coming in the group of 5. So this is called multi-spot laser. It is lesser painful. This is a single spot laser where you have to give each spot differently, and though various studies have shown that the single spot laser is more effective for the regression of PDR. There are various guidelines as to how close you can go to the posterior pole. Usually we like to remain outside the arcades, 2 disc diameter temporal to the macula and 500 microns nasal to the macular area. And we always avoid major vessels and vortex vein ampullae. This is just one slide to show you this patient had PDR, underwent penretinal photocoagulation, showing beautifully how the NVs and the leakage resolve. This is a table I've just taken from Ryan, the long list of complications, just to show you a common one. This is a patient with PDR. You can see some hyaloid hemorrhage, no edema. Underwent PRP, and subsequent stage the hemorrhages are resolving, but the patient has developed diabetic macular edema. So very important to treat diabetic macular edema if the patient has pre-existing diabetic macular edema. If you do a lot of PRP in single sitting, patient can develop a CD. This patient had a macular traction, neovascularization, underwent photocoagulation, went on to develop fibrosis leading to macular hole, underwent surgery, and the macular hole closed. Nowadays, people have tried anti-VEGF monotherapy. It is as good as panretinal photocoagulation for initial 1 to 2 years, but it is an infinite therapy. It never ends. You can't keep on injecting the patient forever. So it's better to treat the macula with anti-VEGFs first. Once the neovascularization and macular edema regress, you can go on to do a PRP so that treatment becomes finite. One of the most important caveats of monotherapy is that when the patient gets lost to follow-up, they turn up with very bad TRDs, and that is very important that these patients should be rigorously followed. Similar results were found in aflibercept monotherapy in clarity trial, but again, one very important thing is that anti-VEGF monotherapy regresses the effects of ischemia. It reduces the effects of ischemia. Neovascularization regresses, but the ischemia does not decrease. So ischemia keeps on progressing. That's why you should not do anti-VEGF monotherapy alone for extended periods of time. There are various indications of vitrectomy, the most common being non-resolving vitreous hemorrhage followed by RD, especially if it involves the macula or threatens the macula. So very few things about vitrectomy. We like to use the preoperative anti-VEGFs. Best would be 3 to 5 days before the surgery, and you always look for crunch. That means whereby the fibrosis contracts leading to TRD. So you must look for it, and if there are signs of crunch, you must operate these patients immediately. We do standard 3-port microincision vitrectomy surgery in these patients. We do not do PVD in patients with diabetic, especially with the membranes. There are various techniques described to deal with these membranes, including segmentation, delamination, and en bloc. Nowadays, we commonly use rollback technique. No scissor or extra instruments are required nowadays. Cutter is enough in most of the cases. And one of the most important things in diabetic vitrectomy is to control the bleed. Bimanual dissection with the help of chandelier is another important tool nowadays in our armamentarium to help to tackle these cases. And once you have done all these things, the membranes are gone, media is clear, then you can go on to do PRP and additional anti-VEGF or steroids if required. So this is one such patient who had a TRD, resolved beautifully after the surgery. So to conclude, PDR is a severe sight-threatening disease. It leads to irreversible vision loss if untreated. It is very important to diagnose and treat it early, and panretinal photocoagulation and anti-VEGF form offer us a very good effective therapy in the management of these cases. And with the help of vitrectomy, now we can tackle very advanced cases very successfully with the improvement in instruments and techniques. Thank you very much.
Yeah. Thank you, Vinod. You have explained so nicely about the PDR, when to act and when not to act and how to act. So when to do the surgery, when to do the laser, how much to do laser. So has been explained so nicely. Any question from anyone regarding?
Thank you.
Ankur, are you ready? A couple of points. Yeah, Ankur, you can come. Diagnosis PDR is by and large clinical, but believe me, you can miss NVE's periphery. So do not be, unless you are very good at screening. All of us have missed NVEs. NVD is easy to pick up. So I, for one, will do an angiography, because in 5 minutes you can see the entire retina. सब कुछ पता लग जाता है, CNP है, macular leak है कि नहीं है. So I tilt towards angiography for the first time if it has not been done. And treatment, as far as is concerned, laser is the mainstay still. And he very nicely said that protocol S came up, which tried, all this pharmacological treatment is trying to deviate us from the main treatment. But believe me, that is not the answer, because it's an infinite treatment, as he rightly said, and we can't afford keep giving injections. So anti-VEGFs have to be used as an adjunct. Do not go with the impression that anti-VEGF is the mainstay of treatment in PDR. And third point was about the surgery part. Surgery, because diabetes surgery is in contrast to other surgeries, vitreous surgery is no two diabetes are same. And use of, although the port size and they become closer, but bimanual surgery, if it is a very severe TRD with scissors, is sometimes the only answer, because you have to take care of two B's. One is bleeding, one is the break formation. You don't want to end up in surgery where you do a lot of bleeding, and bleeding can be taken care of by pre-op anti-VEGF. But if you pull too much, then breaks can occur. So what the advantage of scissors is that it adds precision. It adds precision that wherever you want to cut, you cut. Otherwise, you can have. But believe me, use of scissors has gone down, but it's still there. So, chal, thanks Vinod for showing very good slides. Ankur? So Ankur, actually, whatever lecture he wants to give, I would prefer that he should give a small booklet on all the trials of diabetic retinopathy. Because trials of diabetic retinopathy are so many, and it's impossible, even if it takes 1 minute per trial, 10 trials, but number of trials are so many of them. So I'll request the treasurer is here or secretary was here. Secretary is here. So in case you can compile these trials and with the help of Ankur and distribute to everybody.
Okay, and
So
be brief. Okay, na take home message.
Because what I would prefer is एक trial एक page पे and उसका result इस page पे, so that we can know. Yes, Vinod.
Book.
Show. Love. So where is that? It's available on Amazon or?
Amazon per available.
So wonderful. I think all of you should read that, because trials are important. You can be questioned in exams. In any case, trials make it wiser, because clinical trials are one aspect, but real world scenario is sometimes different aspect. Clinical trials makes you wiser in.
But in the exam, I am taking MD exam. Only they are stuck at the basic finding only. So majority of the people fail at the finding. If you differentiate macular hole and hemorrhage, PDR, and 90-day examination for macular edema, you are passed. Till trial, that means you are having a gold medal. So just to have a brief, all these things. So what is the best method to diagnose macular edema? Anybody? Till he puts up the slide. Macular edema clinically. किसने बताया? मैग्निफिकेशन कितना होता है इसका? 90D किसने बोला? पूरा बोलो. पढ़ लेना. Majority of people fail on this.
So Ankur, how many slides you have and how many trials?
भाई थोड़ा brief करना. नींद आ रही है बच्चों को बेचारों को. Important trial. DRS, CTDRS, DCR network.
So our aim should be not to cover all the trials. You can list all the trials, but tell the salient trials which everybody should and must remember those trials. Yeah, please start.
So that's what I have tried to do, sir. I'm just going to talk the trials in the form of the clinical relevance and the MCQ relevance. So not much about each and every trials. Can I please have those slides individually?
Put one by one. यहीं से करनी पड़ेगी. You have to do from this place.
This has gone into slide.
माउस कर दो. माउस प्ले कर दो सर. उस पे चला रहा ना देख उधर देखता सेटिंग एचडीएमआई को जो आ रही है ना
सर ये चला गया है इस पे एंड
अब देख उधर लेके जा माउस एक्सटेंड ऐसे उठा ले एचडीएमआई जो ऑप्शन आ रहा है उस पे करना पड़ेगा आपको जो वहां पर एक
करो
मिरर करना इसी में जाना नीचे
एडवांस
ऑप्शन
mirror display make it to
mirror
display
Dr. Praful, the audiovisual team.
Good evening, everyone. Thank you. At the very onset, I would like to thank DOS for this wonderful opportunity. So I'm going to talk about clinical trials in diabetic retinopathy. So why do we need these trials, and why do you want to read about this? Because we want to practice evidence-based medicine. And what is that? It's a scientific method to organize and apply current data to improve healthcare decisions. So arbitrarily, these studies can be divided into the type of intervention. If they are metabolic intervention in the form of systemic control, then there are diabetic control and complication trial. United Kingdom prospective diabetic study. When the intervention was in the form of photocoagulation, then the study was diabetic retinopathy study. Early treatment diabetic retinopathy study. When the intervention was in the form of vitrectomy, then it was diabetic retinopathy vitrectomy study. On the basis of intervention, if the intervention was in the form of intravitreals, it can be divided into bold. Bold is for bevacizumab, resolve, restore and rise. It is for the ranibizumab. Thou, Vinci, Vista and Vivid is for the aflibercept. Crystal, Kite and Kingfisher can be for use, are for basically for brolucizumab. Boulevard, Yosemite are for faricimab. And intravitreal studies for steroids are Mead and FAME studies. So then there is an endless list of diabetic retinopathy clinical research network, and they've done a lot of research about these different trials in the diabetic retinopathy, and I would be discussing the few important ones. So let's go to the first study, that is diabetic control and complication trial. So the research question that this study was able to answer was, will the intensive control of the blood sugar slow the development and subsequent progression of diabetic retinopathy? And it was found that if we control the blood sugar intensively in type 1 diabetes mellitus patient, there was 76% reduction in the risk of developing retinopathy, 54% reduction in the risk of progression of diabetic retinopathy, and at the same time, intensive blood glucose control will lead to reduction of neuropathy and nephropathy by 60% and 54% respectively. Another study was, then there was need of a study in type 2 diabetes mellitus patient, and this was United Kingdom prospective diabetic study. It tried to answer the research question, that is, will the intensive control of the blood sugar in type 2 diabetes mellitus patients and intensive control of the blood pressure in type 2 diabetes mellitus patient as well as hypertensive patient will reduce the risk of microvascular complications associated with diabetes, including the risk of diabetic retinopathy. And it found that independently, the blood glucose as well as the blood pressure reduce the risk of development of diabetic retinopathy. And at the same time, it introduced to us with this term that we can use either of the drugs. We can use ACE inhibitors or beta blockers, and both had very good protective role in diabetic retinopathy by reducing the blood pressure. Then there was the intervention studies like diabetic retinopathy study, in which this study tried to answer, is photocoagulation effective for diabetic retinopathy treatment? And the result was that the PRP had a reduction of 50% in severe vision loss, and it also identified that the patient that should be treated with PRP should be high-risk patients. It introduced us with the terminology which is called high-risk PDR, and that is, as discussed before, NVD more than 1/3 of the disc area. Any vitreous, if you see a vitreous hemorrhage in the diabetic patients, it's a high-risk PDR treated with PRP. So then there was a need of another study which could deal with the earlier cases also, because the last study was the target population was only very severe PDR and very severe NPDR and PDR. So we needed a study which wanted to study the earlier patients. So this study targeted mild to severe NPDR and early PDR and tried to assess the efficacy of laser photocoagulation and aspirin therapy in the progression of early diabetic retinopathy into more advanced diabetic retinopathy. It also wanted to answer that when is the right time to initiate photocoagulation and what are the risk factors for the progression of diabetic retinopathy. The results were that severe non-proliferative and early proliferative diabetic retinopathy patients should be treated with PRP, and that too if the patient is a type 2 diabetes mellitus patient with an old age. And it was also seen that if you use focal laser, the CSME reduction was 50% in the moderate visual loss. In the absence of CSME, if you still see a fluorescein leak, do not treat the leak. At the same time, 650 mg of aspirin did not increase the risk of vitreous hemorrhage. So with time things have changed. But these are the initial few studies. So I'm just telling you about these initial studies. Then as we have discussed before, EDTRS introduced us with the term known as clinically significant macular edema. It also gave us with 4:2:1 rule. Then there was diabetic retinopathy vitrectomy study. It compared the early vitrectomy in diabetic vitreous hemorrhage to the deferred vitrectomy, and it found that early vitrectomy was useful in type 1 diabetes mellitus patient. The outcome of the study was based on the visual acuity, so that's why the results were different in the two category, because type 2 diabetes mellitus patient have more of maculopathy. Then there were DRCR protocols. Protocol B, which compared intravitreal triamcinolone acetonide with laser photocoagulation for diabetic macular edema. The study was where it differentiated the central macular edema from the non-central macular edema. That is the MCQ. So at the same time, it was found that the triamcinolone acetonide injections were not superior to focal or grid laser. Rather, it leads to more adverse event in the form of increase in IOP and cataract formation. DRCR protocol I compared ranibizumab with lasers with triamcinolones with laser, and it found that intravitreal ranibizumab plus deferred laser photocoagulation was more effective in increasing visual acuity when compared with focal or grid laser alone or intravitreal triamcinolone with grid laser. Protocol, as was just discussed right now, that can we treat the PDR patients with intravitreal ranibizumab? So it compared the prompt PRP with ranibizumab. It found that ranibizumab is an effective alternative apart from the long-term problems with treating these patients with just injections. It is an effective alternative in this study, and it leads to lesser visual field loss, reduction of patient developing diabetic maculopathy onset. Few patients with treated with ranibizumab required vitrectomy. Proteus study was when we combined the PRP with the ranibizumab, and we found, and compared with the PRP alone, we found that when they put the patient under PRP with anti-VEGF, the patient tends to do better. Protocol T compared the efficacy of aflibercept with bevacizumab and ranibizumab in diabetic macular edema. So it was found that when the patient has initial visual loss which is very less, you can use any of these salts. But then when the patient has a visual loss more, at the presentation, aflibercept was more effective than bevacizumab. Protocol V was to assess whether the treatment is necessary in patients which have very good visual acuity, like visual acuity of 20 by 25 better. So it was found that treatment alone in these patients did not have any significant advantage over, the observation alone, treatment alone does not have any significant advantage. You can just observe the patients, systemically control these patients, and if the vision worsens, treat them with an anti-VEGF. Protocol U was designed to assess the effect of corticosteroid combined with anti-VEGF in persistent diabetic macular edema. And it was found that though when you combine these two molecules together and use these patients in persistent macular edema, it has an anatomical benefit, but that it did not reflect into the visual gain. So you don't want to treat the anatomy, you want to patient have a visual gain. So the take-home message from this study is that it was not of use. Then there was protocol AB that compared anti-VEGF with prone vitrectomy with vitreous hemorrhage, and it was found that when we do vitreous surgery earlier in vitreous hemorrhage, the eye and there is a faster visual recovery in these patients. However, the long-term visual outcome in the patient that received intravitreals with the another patient receiving vitrectomy are same. There are other protocols like protocol A, as we have discussed earlier, predominantly peripheral lesions are better assessed on ultra-wide field fluorescein angiography. Protocol AC told us to be more economically viable. So they compared the aflibercept to begin with the patients for 3 months of bevacizumab and then switch to aflibercept. So when we compare these two, switching and the aflibercept to begin with, the outcomes are same. So we can switch to aflibercept after 3 months, start with bevacizumab, switch to aflibercept, and the visual acuity is going to remain the same. Protocol W had the patient of NPDR were treated with anti-VEGFs, and they tried to see the benefit of anti-VEGF in NPDR, and they found that there is no such benefit of anti-VEGF in the patients having NPDR. Then there are specific trials like for faricimab, there are Boulevard trials that compare faricimab with the ranibizumab. And there are Yosemite and Raynet trials which compared faricimab with the aflibercept and found faricimab to be effective. Then there are Kite and Crystal study for brolucizumab. And there are multiple studies for other salts as well, as like for aflibercept we have Da Vinci study, Vivid and Vista study. For ranibizumab we have Resolve, Rise and Ride and Restore study. And for dexamethasone we have Meet study. Thank you.
Thank you, Ankur. I think one of the most concise and most best lectures I have heard. In fact, a lot of people should have taken photographs of these slides. And as I said, Vinod already has compiled. So I think Dr. Bhalla will do this or publish in DOS time so that at least these trials are effective. You see, purpose of all these trials is that Trials are what we call randomized clinical controlled trials, but real world evidence may sometimes be different. So you don't have to, you have to know them, but you don't have to necessarily follow all these things. That is important, because our RCTs are what we call the red carpet trial, red carpet treatment. Because उसमें क्या होता है कि you know patients get drugs, treatment, everything is free, and you see, and then whatever conclusion is drawn, the compliance there is very high. Whereas real world scenario is totally different. So therefore, all the molecules undergo, apart from RCTs, real world evidence is more important. No, Ankur?
Absolutely, sir.
So I am very thankful. At least first two slides were very good, very good that you summarized, and I hope all of you in the audience should have one slide of each of them.
Thank you, sir. Thank you for the appreciation. Thank you, sir.
Thank you. Now I invite Dr. Lalit Verma. He will be talking on VMT.
Okay, thank you, Dr. Rajpal. And at the outset, I thank the DOS team consisting of Bhalla and my dear friend is here, Treasurer Sahab, and also the RPC for hosting this program. And although topics are more than the time what I was in allotted, but we'll still try to do justice. So shifting gears from diabetes to some surgical issues, which are interface issues, and with the advent of OCT, all of us are learning this. And the reason I'm showing this slide is that this is my favorite slide, because I keep asking everybody, 10 layer retina ki ginao mujhe kitni dikhti hain ki nahi. And OCT maybe every one of you should make these 10 layers by heart. People should not become top consultants by saying that edema plus and give injection. That should not be at this level at least. So on OCT, normally I try to classify pathologies based on the anatomy. Inner retinal pathologies, you see, if we go back to the previous slide, here is the ILM and here is the ELM. This is the inner retina, definition wise. And these three lines which are the most important from vision point of view, that is the ELM and the ISOS junction and the RPE, this is the outer retina. So inner retinal pathology is between ILM to ELM and outer retina from ELM to RPE. But I will be talking primarily about the junctional pathologies. Junction is that where the vitreous meets the ILM. This is the part of the vitreous. So remember that all of us are born with a gel vitreous. Gel is the consistency of a white of an egg. So we are born with gel vitreous, and this gel vitreous is adherent at various places like optic margin, vitreous base. What happens with age, as all of us age or disease or trauma, two things occur. Two things can occur to this vitreous and its attachment. One is vitreous gets liquefied with age. Second is the adhesion of the vitreous with the retina ILM decreases, weakens. If both these things happen parallelly and completely, what you get is a total PVD. And you may get in this process of PVD, you can have flashes or floaters sometimes, or retinal tissue may torn or bleeding may occur. That may happen if both the things occur together. However, if the vitreous gets liquefied, but the attachment is still there, so this is the process, that means adhesion is still there. This will allow the liquid vitreous to go retrohyaloid. So this is what is known as anomalous PVD. This is not a complete PVD, this is anomalous PVD. And you see this process can be accentuated by various diseases or trauma, and this causes various membranes formation also. So this is what is known as anomalous PVD or incomplete PVD, and this explains all this vitreoretinal tractional disorders or VMT pathologies. And this classification also, I think all of you should know, internal classification of VMA, VMT. And here the point to be noticed is about the attachment. 1500 micron is focal, and more than that is broad. And same is true for VMT, focal and broad. Similarly, macular hole, remember that small, medium and large. 250 is small, 250 to 400 is medium, and large is 400. But believe me, in our practice, we rarely get large, we get extra large holes in our practice. So VR interface disorders we'll cover one by one. VMA is basically an anatomical curiosity, nothing much has to be done. because here the vitreous is separated, but it may remain adherent. But important is not pulling the retina. So if there is no pull, there is hardly any symptom. VMT in contrast, where retinal pull gets added. So you can see this pathology that retina is now getting tented up. Because retina is getting pulled up, so the photoreceptors get distorted or pulled up, so you may have metamorphopsia, or you may have CME also. So, but remember, all patients of VMT, even if it's alarming like this, they may not require treatment. There may be anatomical curiosities also. So answer is, do all OCD diagnosed VMT required? Answer is a big no. Please do not treat, because a lot of these patients may have tolerable kind of metamorphopsia, occasional. And sometimes if patient is lucky or you are lucky, total PVD can occur and resolve symptoms. So I'll show you one example of each. This lady was operated for macular hole, and left eye, she was asymptomatic, and this was the pathology in left eye. Vision still 6/6. So you have no right to go inside the eye and treat this pathology. And this patient, you see, this patient I was following up. There was slight element of pull, and this element increased in 4 or 5 months. So I prepared for surgery, but by the time surgery was to be done, this vitreous got separated, and patient had resolution of all the symptoms 6, 6, and 6. So sometimes this may happen. So VMT, you should be very serious in approaching only if the patient is symptomatic. Symptoms, as I said, could be, most important symptom is metamorphopsia. So this is the most important symptom. Otherwise, you can have decreased vision because of ERM and CME, also macular hole. So remember, even if this patient is like this, very alarming kind of VMT, vision is 6/6, please do not treat the OCT. We treat a human eye, not the OCT. But management is to remove this greenish color, membrane, pseudocolor, this membrane, and generally it is done by surgery only, MIVS. And this, ocriplasmin came as if it will steal the bread and butter of a vitreal surgeon, that, this will take away all this VMTs. But believe me, the results were not very good. It came with a very big bang in this 2012, but went away with a big bang also. And the reason was that apart from expense, success rate is around 25–30%. Further, there are complications which were not reported in MIVI trials, but ultimately in practical world, there are a lot of complications reported. And this was one of the studies which compared ocriplasmin versus vitrectomy. In eyes which underwent vitrectomy, result was 100%, whereas where injections were used, results were again 50% only. So surgery is the mainstay. MIVS, as was being told, small incision MIVS surgery, and main step is to do a vitrectomy only and induce a PVD. And PVD induction today with the help of tricot is not very difficult. You do a core vitrectomy, inject some tricot, and gradually engage this vitreous which has been adsorbed onto the on the tricot, has been adsorbed to vitreous. And once you engage, then gradually pull anterior posteriorly as well as tangentially, so that these two rings or two blobs of tricot get separated, and ultimately you will have a signet ring formation here, and this comes out very nicely. This generally is not a very time consuming job. It takes around 10–15 minutes and you are out of it. This is one result. We have an alarming VMT, and after a couple of months, believe me, the anatomical restoration takes months. It's not a matter of weeks, but metamorphopsia goes away pretty fast. This was another patient, who had, this is the alarming VMT. Patient was symptomatic, so we did same core vitrectomy followed by tricot. The only different point we did was that we did a foveal sparing. I did not pull on the macula, because if you pull here, you may create a iatrogenic macular hole. So you can do a foveal sparing PHF peel here. And this was the result of this patient. You see the air is still present here. The result can be obtained like this without pulling at the fovea. The same patient, no ILM peel done, only PHF trimming was done. We did a foveal spin, no aggressive pull on the hyaloid. So second membrane is ERM. Remember these 3 points. Hyaloid is the culprit in VMT. ERM, there is a membrane upon the retina, and then in macular hole the culprit is ILM. And this sequence we should know. And there are 3 dyes available also. For the PHF, the dye available, or dye we should not call dye, it is a tricot or the triamcinolone. And for ERM we use staining with the help of trypan blue, and for ILM we stain with BBG. 3 membranes, 3 dyes we should remember. Again, here again, this is a silent kind of ERM, vision 6/6. Although concavity is lost, but patient does not know anything. So once you have decided to do surgery in ERM, surgery again, after you have removed the hyaloid, I tend to stain these membranes because staining adds precision. You try to avoid complications. So here is a bent MVR blade. With the help of this, we identify the edge. And once the edge is identified, then you can, tease this membrane away from the surface of disc, away from the surface of macula. And generally this will come out in a single plane. There is no schisis here, that will not come out. All the membranes will come out in a single plane. This is another patient who had dry ARMD plus, so we begin with core vitrectomy, put some tricot crystals here. And as I said, engage with the help of cutter suction. Once the vitreous is out, then air fluid exchange was done. And under air, 1 or 2 drops of trypan blue goes inside. This trypan blue is slightly concentrated compared to what you do in anterior capsular rhexis. So after this has been done, you put 1 or 2 drops like this, wait for some time, and then take off this excess of trypan blue. This ERM gets nicely stained, and then with the help of a 25 gauge MVR blade, identify the edge. And once edge is there, take this forceps, and generally this membrane gets peeled off in one go. Generally the membrane size is much more than what is visible anatomically. ERM size is much more. And this was the result of this patient. Generally all these patients of macular surgeries, we do a combined cataract plus membrane surgery, even if the cataract is less, because we don't want, because cataract tends to increase after vitreous surgery also. And ILM peel should be tried in all patients, but not at the cost of damaging the retina, especially in ERM. So even global trends say that ILM peel is not a must. If you remove it, well and good, because this will take care of the future formation of membranes. Last is macular hole. And macular hole surgery has become very simple nowadays with the advent of this BBG dye. So we have removed all the membranes, the PHF. Aim is to create a nick in the ILM, and various things have been tried. So this diamond dusted came with a very big hope. We used to use diamond dusted, but now we do direct pinch and peel technique. Directly you can, take this forceps, pinch the ILM, and then do, and the first surgery itself try to peel off ILM arcade to arcade. And this is showing ILM peel where, this ILM is taken across the macular hole. Is taken across the macular. This surgery is very good for small to medium sized macular holes, say till around 3 to 400. But if the hole size is big, then this surgery may not be as good. So this is post-op result of the same patient which I showed the surgery, and the restoration of anatomy, and the hole is less. This is another patient showing good result. So a lot of things have happened in macular surgery over the course of duration of tamponade. You see, there were days when we used to advise strict prone down position. Now no longer. Even head tilt is good enough. So do not scare your patient. Even if the patient is an obese, fat lady, even this reading position is good enough for tamponade. And believe me, holes are known to close within 24 to 48 hours. So post-op positioning is not mandatory that you confine the patient to bed for long time. And a lot of other things have come out which I'll discuss. This was one patient who had all the components. Like he had a VMT, he had ERM, he had a macular hole. So this is 3-in-1 kind of surgery. In fact, 4-in-1 because we combine cataract surgery also. So same steps are being shown here, that we remove the tricot, this hyaloid with the help of tricot. Then under air fluid exchange, we put 1 or 2 drops of trypan blue, stain this membrane, identify the edge. Identify is very important. That once this edge is identified, then take hold of this Acard forceps, very useful instrument. And this is the epiretinal membrane which is coming up. And once the epiretinal membrane was out, the surface of the retina was still not smooth. So we put in the third dye, that is the BBG here. And this is the BBG going inside the same. And then again, pinch the ILM and take out the ILM in this. So this was the 3-in-1 kind of surgery done in the same eye, and this was the post-op result of the same patient. Fortunately for us, this patient improved from this anatomy to this anatomy, and from 6/24 to 6/6. So it is possible today to restore and give good vision in all these macular hole surgeries. So what has happened recently is that instead of peeling, people have shifted to various other crazy surgery, I should say. People have gone to flaps, people have gone to autologous retina, autologous lens capsule also. So this was my first patient which I did a flap surgery after I came back from ASRS in 2016. This lady was with me at RP Center, but I operated in Center for Sight after a gap of 14 years. And this was the flap, my first flap surgery. The difference here is that instead of peeling the ILM across the hole, we are leaving at the edge of the hole. This is the flap. So we create multi-layered flap, but each flap is taken till the edge of the macular hole. But remember to take till the edge of the macular hole, otherwise the surgery may not succeed. So multiple petechial hemorrhage may form, you don't have to worry for those things. And I like to trim this at the 50 suction as well as maximum cut rate to some, and sometimes these surgeries may require some massage of that area so as to oppose the edges of the hole. So with the help of diamond dusted, you can sometimes try to oppose. I don't like this tugging of the ILM into the hole, because that way you will traumatize the RPE. So don't try to tug it inside. And this was the result of this patient. See, this hole is 1400 micron in size, and this hole still had type 1 closure. This was one example, you see, where surgery had not succeeded, although it's not very common. The results of macular surgery are to the tune of 90-95%. And this patient had ILM surgery done, but did not succeed. It's a very large hole, very old hole. And what we did in this hole was that we did prepare this, ILM graft here. So this was done with the help of diamond dusted. And once this was done, this had to be put on the macular hole. So you have to stabilize the posterior pole, put few drops of PFCL. Otherwise, if everything, all the ports are being done, this positioning of the flap may get disturbed. So do all this moving of the flap from the, say, infranasal area to the that area under the PFCL. That way it will go on and stick in that area. So here this is being positioned at the macular hole. And you see, you can put a couple of ILM grafts here. So once this is done, now aim is to remove the PFCL. If you remove PFCL, they may get dislodged. So what normally we do is put 1 or 2 drops of visco there. So you will see that with the help of that back flush, this is coming out PFCL, but with the other we will put couple of drops of visco there, so that this flap stays there. Even if the flap stays there 1 or 2 days, believe me, this does the job. Another thing which will be shown here is sometimes we will create a detachment, or we call hydro dissection of the macula. So what this will take a thin bore 42 gauge cannula, and with the help of although automated things are also available, this is manually being done, that you create a detachment and you'll see some fluid coming out of the macula. The aim is that this hole's margin should become slightly more elastic. If they're too rigid, it may not flatten. So then you do fluid exchange and come out of it. So the world today is, believe me, divided between peelers and non-peelers. And peeling is generally done in smaller macular hole. Peeling may succeed up to, say, 300 or so. If the hole size is big, what definition I told you, 400, then generally flap surgery is required. If it is further big, say 600 or so, then other things are required. So you see, the reason I am telling you is that this is a copied photograph. If the height is more, then ILM peel may be successful. But as the hole size becomes larger means that MLD, that is the minimal diameter, as the basal diameter, they become more or less same. Whereas the hole is like this, then minimal diameter is less compared to basal diameter. So if the height is more, then peel will succeed. If, however, the base is more, then you have to resort to other pathologies. And in such conditions, you see autologous retinal transplant or ILM transplant or amniotic membrane have been used with success. And this is one of the latest, thing. Close classification has come out, where they, as I was telling you, small, medium, large, but people now talk of X large, and like we get T-shirts from the market, shirts. XX and giant macular holes also. This, more than 650 is extra large, more than 800 is XX and giant. In fact, most of our practice consists of either XX or giant macular holes. And so many techniques, as I was telling, if you do a flap surgery in large macular, it does succeed. If you do peel, it may not. So therefore, in practice, surgery, it's not a forgiving that you keep doing multiple surgeries. In the first go itself, you have to, succeed. And visual results also are reasonably good. In extra large macular holes, it may not be very good, but still patient will improve. So this is one algorithm which people follow. The only point to be noted is sometimes if the axial length is say more than 30, then even all these surgeries of flap or perifocal dissection or retinal transplantation may not succeed, and you may have to resort with either a macular buckle or a scleral imbrication has been described to shorten sclera so that this hole can close. So thus I'll like to conclude now by saying that OCT and newer theories of this anomalous PVD which I've told you have now helped us in better understanding of these interface disorders, and believe me, success rates of all these things have improved with the help of MIVS. Thank you very much for your kind attention. May I pay tributes to my mentor, Dr. Tiwari, of whom photograph I have shown here.
Thank you, Dr. Lalit. Now I invite Dr. Avindra Gupta, who will be talking on the ARMD. So anybody would like to ask any question?
Any
I think you must have understood.
So now we'll have talk on ARMD again. A very vast topic. Dr. Avindra Gupta, senior consultant with us at Center for Sight. I think a little tough job, but 10 minutes he will tell us some salient.
First of all, I'd like to thank DOS for giving me this opportunity. In an era of reels and videos, the showstopper has already taken the all the magic of the show, and he has shown such a beautiful and breathtaking videos that I think all the audience are going off. And we'll be talking about degenerative disease, that is age-related macular degeneration. I'll be talking about different presentation, diagnosis, and management. There are two most important things in old age. One is reading and second is watching television. So in age-related macular degeneration, central visual acuity is affected. AMD decreases all aspects of patient quality of life, including the patient ability to drive independently, and this leads to depression. If you look at the epidemiology, AMD is the leading cause of irreversible visual loss in United States. 10% of the population above the age of 65 to 74 are affected, and if the age increases to 74, the incidence increases by 25%. Approximately 10 to 20% of these patients are exudative form, and exudative form is responsible for the visual loss in age-related macular degeneration. Age-related macular degeneration is characterized by drusen's, pigment abnormalities, CNVs, pigment epithelial detachments, and scarring of macula. It can be basically classified into dry and wet. Dry involves drusen's, pigmentary alterations, hyperpigmentation, and the cause of vision loss in dry age-related macular degeneration is geographical atrophy. Wet age-related macular degeneration, which accounts only 12% of age-related macular degeneration, where the major loss of vision is because of the wet age-related macular degeneration, is because of CNVM, serous or hemorrhagic RPE detachment, tear or RPE rip, and fibrovascular scar. 90% of blindness in AMD is due to wet type. If you look, the primary presentation in age-related macular degeneration is a drusenoid presentation. You can see this yellowish lesion at the posterior pole, and if you have multiple drusens here, then the diagnosis of dry age-related macular degeneration is made. On fluorescein angiography, you will see this as in hyperfluorescent areas. Drusens can be classified into hard drusens, which are tiny, round, discrete, or distinct margins. large drusen's which are more than 63 microns in size. Soft drusen's with indistinct margin tend to be large. Confluent drusen's due to merging of soft drusen's and they can become calcified drusen's. And if you have a lot of soft drusen's, it can become into a drusenoid RPED, what you see here, which are confluent drusen's extends more than 500 microns in diameter. If we do an OCT in drusen's, you will see an RPE undulation, which is diagnostic of drusen's, but it doesn't have any clinical significance because it does not progresses much. This is an autofluorescent picture, and you can see these black areas. These black areas are areas of geographical atrophy, where whole of the retinal tissue is lost. And because of this, in patients of dry age-related macular degeneration, you will have a visual loss. And this is one of the interesting patients. If you look at this patient, pseudophakia, both eyes near normal. We did a color vision, fields near normal. And if you look at the OCT pictures are near normal. So anybody with the diagnosis, what is the diagnosis here? If you look at the choroidal thickness here, the choroidal EDI is somewhere around 210. And if you look the choroidal thickness is just 190. So we come to a newer diagnosis, what we call as an age-related choroidal atrophy. No changes in the fundus, only the choroid is thin, and this can be only diagnosed on OCT, on EDI OCT or swept source OCT. Coming to wet age-related macular degeneration, it usually presents at yellowish white lesion, and if you have subretinal hemorrhages along with that, it's diagnostic of CNVM. And fluorescein angiography, you will find a lacy filling, and on ultrasound, you will see a thickening at the level of RPE with edema, intraretinal edema. It accounts for 10% of ARMD, but 90% of the blindness in age-related macular degeneration. CNVM, according to the macular photocoagulation study, can be classified into subfoveal, juxtafoveal, and extrafoveal. These two are now not important because in these two lesions, if you have subfoveal and juxtafoveal lesions, then the treatment is anti-VEGF. But important thing, these extrafoveal lesions are 20% of the all lesions in CNVM, and you have to identify these lesions because you can treat these extrafoveal CNVMs with laser photocoagulation and can give a finite end to the treatment. At the classification, you can see based on macular photocoagulation study, topographic classification, which we have already discussed. Then you can have an angiographic classification, that is classic and occult. And now with OCTA, you can have, according to the location, you can have type 1, type 2, and type 3 CNVMs. Type 1 is sub-RPE, that is PCV. Type 2 is subretinal, that is classic. And type 3 is RAP lesions, and all these lesions we'll see in subsequent slide. This is one of the patient. You can see a fluorescein angiographic picture. You can see a yellowish lesion here. And if we do a fluorescein angiography, you can see a lacy kind of a filling with late leakage. These are OCTA pictures. You can see on OCTA, there is an membrane here. And on OCT, you have an SRF with an RPE complex thickening. So what we did, since it's an extrafoveal lesion and with some amount of fluid, we gave one injection of ranibizumab, and you can see after 30 days, this is the laser mark here, and after 30 days, you can see on B-scan photograph, the fluid has almost disappeared, and after 60 days, only one injection and laser photocoagulation, we are able to treat this patient without multiple injections. So please don't miss this extrafoveal lesions because these lesions are important, and you can treat this, give a finite end to the treatment in patients of choroidal neovascular membrane. These are the OCT pictures. You can see the normal contour returning within 60 days with one injection and laser photocoagulation. Occult CNVM usually presents with pigment epithelial detachment, and if you have a notched PED, there are PEDs which are regular, and if you have a notched PED, what you see here, then it's diagnostic of an fibrovascular pigment epithelial detachment, meaning thereby you have a vascular membrane inside this disease. And in these cases, you need an ICG angiography. You can see this is a beak-shaped PED. This is a notch PED. And at the beak, you can see there is a leakage, which is an PCV kind of a lesion. And these lesions needs to be identified and treated. One important thing is many a time you confuse these lesions with juxtafoveal telangiectasia. These are benign lesions and does not need any treatment, and usually presents as grayish discoloration, temporal and nasal to the fovea. On fluorescein angiography, you will have a leak, but on OCT, you will have a nerve fiber layer defect. You need to identify, you does not need to inject this patient, only you need to observe this patient. If you have a pigment epithelial detachment with large bleed like this, then always a doubt of PCV occurs, and these are the patients with polypoidal choroidal vasculopathy, where you have an extensive retinal bleed. Important thing here is PCV accounts for almost 30 to 50% of the patients in Indian and Asian populations. So we have to identify this disease, because the type of treatment what you are going to give, it's not ranibizumab. You have to give either brolucizumab or aflibercept in these kind of patients. It presents between the age of 50 to 65. 10 to 15% of the patient in Western population are affected, but in Asian and African population, it is as high as 48%. Usually presents at, this is an exudative form of PCV. You can this is an exudative form of PCV, where you can see an orangish polyp here with exudate. On fluorescein angiography, you can see the polyps here. The diagnosis comes from ICG, and you can see these polyps here confirming the diagnosis. And these patients require either aflibercept or brolucizumab. Does not respond very nicely to Avastin and ranibizumab. A short note about RAP lesion. It is a type 3 CNVMs, and it starts in the retina, and in stage 2 it pulls the retina up, creating an pigment epithelial detachment, and then it proliferates below the pigment epithelial detachment to form an choroidal neovascular membrane. Luckily, these patients, the number of patients of RAP are pretty less, but they are very resistant to treat it. This is one of the clinical example. What you can see an hemorrhage here. On OCT, you can see this is an intraretinal lesion with a pigment epithelial detachment. Coming to the management, it started with in pre-1980 era, there was no treatment. In 1980s came the macular photocoagulation study, where we were able to treat extrafoveal and juxtafoveal lesions. But now we don't treat any juxtafoveal lesions, we only treat extrafoveal lesions with laser. In 2000 till this time, we were not able to salvage the eye, and then came the photodynamic therapy in 2000, where we started talking about stabilization of vision. The major breakthrough in AMD therapy occurred in 2006 when anti-VEGF came, and we started injecting patients, and at this stage we started talking about improvement in vision rather than stabilization in vision. In 2018 and beyond, we started talking about increased durability, reduced treatment burden, and improved anatypical outcomes. If you look at the razumab in 2007, what we started with 3 loading doses followed by personalized treatment in maintenance of visual acuity. In 2011, we started with monthly treatment with stabilization and then PRM. Then came the myopic CNVM, where 1 injection followed by PRN, and then 2014 all other indications. This is basically a chart where we started in 2007 with Marina and Anchor trial, where they said you keep on injecting monthly to retain vision of 8.1 letters. Then because the economic burden and the load was too high, so they planned with observe and plan, wait and extend, treat and extend, PRN. Now these two treatment regime are the mainstay of the treatment, that is treat and extend, and PRN treatment, that is as and when required. What is PRN treatment? PRN treatment is you give 3 loading doses once the macula once the macula becomes dry and the vision becomes stable. You keep on observing the patient with visual acuity and OCT. The moment the vision goes down, you start injecting again, then stabilizes. That means as and when required, but the problem in PRN regime it's a seesaw pattern. So many time in seesaw pattern, the vision is usually over a period of time, patients had a reduced vision. Now the most followed in regime in the West is treat and extend. Treat and extend means ki you give initially. Treat and extend means you initially give monthly doses. Then without the disease, treat and extend man, you have to treat the dry retina. You don't have to wait for the edema to come back. So even if the disease does not come back, you extend it to 6 weeks. Then the second injection you keep on increasing by 8 weeks. And the moment if you increase by 12 weeks and you see the edema comes back or intraretinal fluid comes back, you reduce by 2 weeks, that is 6 weeks. So this is treat and extend regime. One of the patients here, you can see this is in subfoveal CNVM. We gave 3 loading doses of intravitreal ranibizumab. You can see the improvement, the SRF and the IRF decreasing over a period of time. These are the OCT pictures, OCT angiographic pictures. You can see the membrane here. After 2 doses, you can see the membrane has almost regressed. The macula has become dry. The vision gains achieved with ranibizumab administered as needed using treat and extend. These orange thing what you are seeing is in PRN, and these are the treat and extend pictures. The number of letter gain in PRN was somewhere between 8.2 to 7. In treat and extend, the maximum which was achieved was 10 letters. And the mean number of injection remained the same with PRN and treat and extend, but the number of visit decreased from 12 to 8. So this decreased the financial burden on the patient. In LUCA study, if you see, it's a comparison of ranibizumab and bevacizumab for neovascular age-related macular degeneration according to LUCA's treat and extend protocol. This line is for bevacizumab and this line is for ranibizumab. The number of letter gained was 7 to 8 letters. The results of either bevacizumab or ranibizumab was almost the same. So to conclude, extrafoveal lesion should not be missed as early diagnosis and treatment can give finite results. Choice of anti-VEGF depends on the type, subtype of lesions and financial status. Classic, occult or minimally classic and RAP lesions, anti-VEGF is the first line of treatment. PCV and pachychoroid spectrum, aflibercept and brolucizumab is the first line of treatment. Treat and extend regime gives the best results with optimization of the visit. Thank you very much for your kind attention.
Thank you, AG, for this summarizing the management of AMD. Before I call my close friend Shashinath Jha, because Shashinath Jha, we have spent a lot of time here together in RP Center. Now he migrated to Gangaram and I stuck to Center side. Shashi will be speaking on pachychoroid. Pachychoroid is an entity which has been, newly recognized. Not new, it's now a decade old, but to me it's a dust diagnosis that everything what where a choroid is thickened, you put into it. So it is definition wise, there are 3 definitions which he will tell. But what AG said was primarily about the wet ARMD. But believe me, a lot of things is now happening on dry ARMD. A lot of things. In this year itself, 2 molecules have been approved by FDA for dry ARMD. And one I remember is, they target the complement pathway. One is anti complement 3 and other is anti complement 5. You should read that complement pathway clotting wala. So the one is PAX-CETA plan and the other one is some PGOL which targets the anti complement 5. And also what is happening in other dry RMD is molecules are being discovered which alter the mitochondrial function, which are at the early stage of. You see these two molecules which I am saying, this one got approved in August of 2023 FDA approval. This is for geographic atrophy. But for intermediate ARMD, people are now working on mitochondrial level of, and two molecules are at level 2 of trials and are showing reasonably good results. So dry RMD also is, gaining importance. All the focus till this time has been only on injections, but dry RMD is an area of lot of research. So now I welcome Dr. Shashi for telling us something about the pachychoroid.
Thank you, Lalit. Nice interacting with you for a long time, and I'm thankful to the organizers for giving me opportunity and thanks again them for giving me a topic where I'm both a student and teacher. As he rightly said, pachychoroid was a non-existent entity in our time, something we never heard of. So choroid is something that we all have noted. The 5 layers, the choriocapillaries, Brooks membrane, hilers, settlers, but possibly all the glamour was taken away by the retina. Choroid was never given any due importance. And of late, with the new studies, we are able to understand how the choroid works and how it can affect the ultimate the neovascularization of the retinal tissue. So it's a backstage worker. And the peculiarities of choroidal vasculature is no auto-regulation as compared to the retinal circulation, and is subject to the vagaries of circadian rhythm. The high intraocular pressure can affect the choroidal circulation, can affect otherwise. But retinal vessels auto-regulate. And you will be surprised to know that oxygen consumption in the retina of the eye is highest during the sleep, because the rods are the oxygen guzzlers, and most of this load is on the choroidal circulation. So pachychoroid is something right now it has come up. Here there is a difficult to understand which way it works. Whether the choroidal vessels dilate first and compress the choriocapillaries, or somehow the choriocapillaries get damaged and then it leads to the, say, reactive dilatation of the choroidal vessels. There is different opinion, which of course with further studies, when the molecular thing comes in, biochemical and genetic things will come to know. And it has posed more questions than it has answered. Actually, this is such a big spectrum, and we are trying to associate many things with the pachychoroid, which may not be true, which possibly will get the answers in the future. And maybe it is a part of the publish or perish group also, because sometimes people just go for publishing anything which can get attention. The word pachy in Greek, of course, we all know is a thick, and therefore pachychoroid literally means a thick choroid. When the basic thickness of the choroid has gone up due to some reason. So common features of pachychoroid disease is a dilated outer choroidal vessels, which shows hyperpermeability as shown in the arrow here, and the choriocapillaries and retinal pigmentothelium attenuate with or without increased choroidal thickness in a focal diffuse area. Here the question comes, because here sometimes there can be only localized affection. So how it works, nobody is very clear. So when compared to ARMD, the affects comparatively younger population. This is very important to know, and does not have multiple dosage. This is one way to distinguish any pathology, whether it is a primarily AMD that we understand. And good thing is that it has a favorable outcome, treatment outcome, possibly because here the tissues are not that much damaged as in the AMD, age-related AMDs. The mechanism for development of the pachychoroid, as already I have indicated, that it could be either way, that it can be first damage to choriocapillaries, reactive dilatation, or the dilated choroidal vessels pushing on the choriocapillaries. So chronic choroidal inflammation and is in this ischemia and predisposed to angiogenic factor release, which will, together with overlying RP Brooks membrane disruption, leads to type 1 CNVM formation. You will be surprised to know that we have the Lalit and all of our generation has come across such a different type of terminologies that will be, I think, aghast to know them. Now we understand differently, of course, after the OCT has come. So OCT has made such a big difference to the life of the retinal surgeons. So coming to the basic types, the pachychoroid pigment epitheliopathy, here the disease is very localized. So maybe there was a transient damage to the choroidal circulation, and only after that it recovered and limited the disease to only that area. CSR, as we know, it's such a thing that we have really don't know what actually causes CSR, and whether the acute CSR and chronic CSR are the same disease or they are different diseases altogether. Pachychoroid is being attributed to some extent to lead to this CSR, but I don't think we are really at the end of the answer of this question. Of course, pachychoroid neovasculopathy, as we already told, the younger patients, if they get new vessels without any drusenoids, the possibility is because the things is coming from the choroidal area. And PCV, of course, is so widely talked, Dr. Avininder talked about it, and it's such an important thing now in the whole spectrum of the AMD. These are the new things which is coming up: focal choroidal excavation, peripapillary pachychoroid syndrome. So actually what is happening that as the OCT is advancing, the different they are able to pick up the breakdown areas in the choroid in different level, and so new terminologies will keep on coming up, and we are likely to face much more in the coming days. So common clinical feature, this is very important, that the normal fundus tessellations are decreased with or without pigmentary alteration. OCT, choroidal morphology, and the stroke-choroidal junction may be studied either using, but you should have all these machines to study them. Routine OCT will not help you to study the thickness of the choroid. And the choroid thickening may be diffuse or focal or foveal or extrafoveal. So this is again important parameters that you calculate. If it is more than that, then it falls into the category of the pachychoroid. So there is no particular threshold value of subfoveal choroidal thickness, but normally 300 plus is supposed to be something very significant. And in case of extrafoveal thickening, see more than 50 micron from SFCT, that is subfoveal choroidal thickness, is become significant. Sometimes what happens that the outer choroidal vessels in the hallux that get dilated, and it seems a hyperreflective lumen with large diameter on cross-section OCT. Sometimes it can happen that the overall compression itself can give rise to a choroidal thickness not being that high, but the disease might be there. So focal or diffuse attenuation of the choriocapillaries and intermediate size choroidal vessel layer, this occurs overlying the pachyvessels. So again the question remains the same. So I will not go into detail about this part, we will go straight to the disease part. And of course here we can have an end-phase imaging in routine OCT machines also. And this is an important thing, the abnormally dilated channels may not taper but terminate abruptly. So you have to keep on studying. Normally we don't study that closely the end-phase images, but you can keep on trying in your machine if you have one. ICG, of course, is the thing to study the choroidal vessels that we all know. It made a big difference to our understanding of the choroidal vessels and the disease related to that area. So in early phase shows a delayed arterial filling, while mid-late phase shows punctate hyperfluorescence, a choroidal vessel hyperpermeability, and it occurs due to the leakage from the dysfunctional outer choroidal vessels or choriocapillaries. The apparently normal fellow eye may also have such ICGA finding. This is very important in case of CSCR. We always see that even the normal eye can have changes in the RP and the choroid. So this is a disease entity that I was talking about, the pachychoroid pigment epitheliopathy. It's only localized thing. Why it happens, only why it has stopped here only, it has not progressed to the further level of disease, is very difficult to understand at this stage. And this is not visually very significant, so it doesn't get much of attention. Sometimes we diagnose that as AMD, but nowadays with these new machines, you can really pinpoint and find out the cause. So OCT shows a focal areas of RP alteration, as such attenuation thickening along the pachyvessels and choriocapillary attenuation. So these are thickened choroidal large vessels, and this area gets compressed and attenuated. Other way around, what has happened, we'll come to know later on. But there is no evidence of subretinal fluid in choroidal neovascular membrane or outer retinal change. This is very important. So that's why it doesn't make much of a difference to the patient as such in general. On autofluorescence, of course, you can pick up these changes in the RP. And FFO shows that we all know that these granular appearances, and ICGA will show corresponding area of the mottling and hyperfluorescence. This is interesting that we come across one very commonly, and really we don't know exactly what is happening still. In the beginning, it was considered a central, say, retinitis of thing, and now gradually we come to know that possibly there was RP coming into play, and now we know there's the pachychoroid, the choroid playing a bigger role than otherwise. So this is something that we still have to understand gradually. So we all know that the two phases, depending upon the duration, less than 3 months, more than, but this is one thing that what I've tried to understand, that this may be a different type of disease altogether, because these patients are different. They keep on losing their vision in due course of time, and PDT did offer some hope. Nowadays we don't have much of, the drug is not available in India. So NSD at posterior pole, which appears an elevated transparent area with well-defined margin. PED may also be present, which appear as smaller, well-defined orange elevation deeper to the NSD. So you can clinically also pick up, you are very careful on slit lamp with the 78D, you can pick up these changes very easily. And sometimes there could be a subretinal fibrin. These are the cases which might not recover fully their vision. Again, the involvement may be foveal or extrafoveal, or as we all know that unicentric or multicentric. In our time, sometimes we used to give anti-tuberculous treatment also in the multicentric cases. And these are chronic cases. See this autofluorescence showing you that track. So I don't know whether we are dealing with the same disease entity or is a different thing altogether than acute CSR. Of course, the NSD and PD, both of which are serious, usually optically clear. This is a PD, this is the serous detachment. And this is very commonly seen. This is something that you will always be very easy to diagnose. And these are the new things. If you have those machines, you can pick up the pachychoroid in these patients and relate them to the basic cause of the disease. FFA, of course, this is a classical description of the leaks at the level of RP in the form of ink blot or sometimes smoke stack, the classical description that you must understand and know. Smoke stack is slightly in the acute phase of the disease, and once there is an ink blot, generally that means the disease is now settling down itself. And ICGA shows the common clinical findings, and OCTA rules out the presence of CNVM, because many times what will happen that in chronic cases of CSR, you might even associate CNVM. So it's very important, if the case is not behaving normally, you must look for CNVM in these patients also. So these are, of course, the images that already we have discussed. We'll move on to the next slide. So this is a pachychoroid neovasculopathy. This is something that has come up new, and this is very important, because here you will find that it behaves slightly different than the normal AMD that we come across. And in the beginning, of course, we all used to diagnose them as AMD, as idiopathic CNV. Now the current literature shows a distinct form of AMD, and PAV mostly occurs in the young adult males. So whenever you have an AMD, young adult males, try to look for the features of this type of disease than the routine AMD. And fellow eyes may have features of other pachychoroid disorders. So CNV basically is the primary feature of PNV, which may be foveal or extrafoveal in location. See, shallow irregular PED with internal reflective sensitivity for the type 1 CNVM. A double layer sign, of course, in this area where the Brooks membrane and the RP, they split together and then form 2 layers. And this is something very important. The subretinal or intraretinal fluid may be scanned. So you may not be, misguided that these patients may not need treatments. You should be very careful and must treat these patients. And FFA shows, as the CNV lies external to RP, when we seen as occult membrane on FFA. We used to call them as occult in our time, but now, of course, we have a new technology, terminology available for this. And stipple hyperfluorescence in the late phase. ICGA findings are the most important, non-specific, no participation branch Western network on the ICGA. So this will basically differentiate it from the polypoidal lesions. And OCTA shows a tangled Western network corresponding to the sub-RP CNVM. So some of these gadgets now with the multimodal imaging is very important once you diagnose these patients. So these are these pictures that we have an autofluorescence like this, and the OCT pictures like this, and not much of fluid. This is very important. This is very important to understand. Some of the myopic CNVM also can present like this, but you have to be really very clear that we are treating what type of disease entity. And of course, now the talk of the town, polypoidal choroidal vasculopathy, that we all know That is a recent realization that most of our patients can having this. So it is characterized by multiple recurrent serosanguinous bilateral PEDs. This is very important that there is a blood content in the PEDs, and also known as the invisible type 1 CNV, as there occurs sub-RP CNV with polypetal vascular change at the level of choriocapillaries. Clinically, polyps are seen as orange bulging lesion in the macular and peripapillary area. So whenever you are examining macular area and suspecting any AMD, kindly look for this orange type of appearance, which might be indicator of a PCV. And of course, the blood is the hallmark of these vascular lesions. Intraretinal subretinal heart exudates, yes, normally in the beginning you don't find much of these changes with these patients, but subsequently if the patient comes late to you, you will see the intraretinal subretinal heart exudates. This is something very important. Whenever you say massive subretinal or sub-RV bleed, always think of PCV. And correctly, there is the absence of features of the ND as the multiple soft drusen and geographic atrophy. Again, this is something that you have to really look for in these younger patients. If you don't have a drusen and geographic atrophy, possibly we are dealing something with the pachychoroid disease. This is something that in routine OCT also you should look for this type of PEDs. The tall pig PED, there's a sign of most likely PCV. So even routines OCTs you can pick up, and these are the patients you have to really advise in a different way. The routine possibly aflibercept will be a better choice, or the newer drugs we are coming up, they're better choice than ranibizumab. And FFA shows ill-defined stipple leakage from polyps, and BVN suggestive of occult CNBM. They may not be that clear, but on the fluorescein angiography, like this. Cases with subretinal bleed shows blocked fluorescence in the area of bleed, and fails to highlight the choroidal vasculature. And of course, the ICG will delineate the branch vascular network very clearly. And leakage from the polyp appear hyperfluorescent nodule at the end of BVN with a halo of hyperfluorescence usually appearing within the first minute of the injection. So this is very important to note, that a halo, because the blood supply may not be picked up that easily at that point of time. And octa appears the hyperflow complex the level of the Bruch's membrane. The flow level in the polyp again is below the threshold for octa and may not pick up the fluorescence at that time. And polyps may appear hypoflow round structure or hyperflow structure with a hypohalo. The limitation of octa is inability to visualize the pathology in the presence of subretinal bleed or exudation. So these are the findings that we have. See the fundus photograph, then you have the OCTs, and then you have the fundus fluorescein angiography, and this is of the ICG. So you see the hot spots, and this is the branch vascular network. So you actually, these are the patients where the multimodal imaging comes into big role and for your diagnosis and the management of these patients. This is something new pachychoroid, which I believe will keep on adding. This is a focal choroidal excavation. This is something very new to me also. I have not tried to look for any of these disease areas. So there is a focal area of choroidal excavation in the absence of disease known to cause choroidal thinning and without any evidence of scalectasia or staphyloma. It is usually unilateral 4th and 5th decade, and no gender predilection, and myos being more involved. Symptoms, diminution of vision and metamorphopsia can be present. FC is believed to be a congenital choroidal defect hypothesized to arise from the RP retraction due to the local scarring of choroidal stroma from previous inflammation. I think we'll take some time to understand this disease entity. The association of FC and CSE and PC well known and not associated with any systemic abnormality. So I think with the OCT coming in a big way, and with the new generation, we'll be picking up more and more of these changes in future, and diagnosing something bizarre and new, which we were not exposed. So I'll not go into detail of this, the focal excavation. This is something very, very new which is coming up. But you should be aware of these findings because you might be asked sometimes in the examination. Sometimes they can be associated CMVM also. So you have to be aware of this disease entity and look for any changes. This is again peripapillary pachychoroid syndrome. It's again a new thing which has come up. Pachychoroid features are found in peripapillary area, nasal macular than the fovea. It is often associated with hyperopia, crowded disc, and choroidal folds. A compartment syndrome-like situation arises in peripapillary area, which leads to optic disc edema and crowd disc appearance. The disease may be misunderstood as uveal effusion. This is important to understand for you, that it could be taken up as uveal effusion syndrome due to associated short axial length and serous renal detachment in the postural. But the absence of choroidal detachment rules out the same. So this is an important picture, that you must rule out choroidal detachment in these patients to reach this diagnosis. So it's the clinical features: intraretinal or subretinal fluid in peripheral area and optic nerve head edema in some eyes. FFA shows motile hypofluorescence and gravitational tract in the peripapillary area like this, and FA shows window defects in the corresponding areas without focal leakage. Mild late disc leakage may be seen in majority of these cases. So these cases again need to be possibly analyzed more closely and understood better to reach a diagnosis.
Thank you.
So I think we'll not go into detail of the management because most of them have discussed.
You have told about.
Yeah. Thank you very much.
Has told a lot of things, and which is very difficult to digest, you know. Before
the only comment I would like to make is a lot of us have to sit down with Shashina Jha to understand all these things, because all these 6 entities which he spoke about. You see, mind you, what is happening now is that the focus is shifting from retina to choroid now. So, you know, all the OCT features what we used to learn on for retina, now the attention is shifting towards choroid as the method. Therefore, the time domain OCT is out, absolutely out, nobody. Then came the SD OCT, now SS OCT. So if you want to understand this, as Dr. Jha made very clear, you have to have either SS OCT or a EDI facility, otherwise you will not pick up all these entities. So thanks, Shashi, for adding a lot of confusion to already existing.
If you have not understood, you can talk to him on the tea or dinner.
Only terminology is treatment has not been touched at all.
Yes, yes.
So that is not important. You should be able to diagnose to pass the exam.
So in any case, let's now come to the second last talk, I think, which is by Dr. Rohan. A very important topic that is on vascular blocks.
And please take less than 30 minutes, okay?
Yes, sir.
10 minutes.
Okay, good evening, everyone. I think it's been a long day for you. I'll have to shake all of you up if I want you to listen to me, I think. So I'll try that.
What I was thinking was at least, DOS people or RPC should provide tea here only.
So I think inside the auditorium it's not allowed, but okay. Anyway, so I'll be talking on vascular occlusions. I'll try to restrict myself to some photographs so that you can learn how to diagnose the basic vascular occlusions and then go about the basic investigations and just a basic approach to the management. Okay. So let us start. They can be either venous occlusions or they can be arterial occlusions. So let's start with central retinal vein occlusion. Very simple. If you see hemorrhages in all 4 quadrants, if you see tortuosity and dilation of the major arcades both above and below, you make a diagnosis of CRVO. Mostly it is a unilateral condition. Rarely do we find it bilateral. So this is a picture. You see hemorrhages all 4 quadrants. Sometimes it obscures the disc margin. It gives a pseudo-edema like picture. There can also be a true disc edema in CRVO. Here it's not showing the dilation and tortuosity because the hemorrhages are obscuring it. But in certain cases you can make out the tortuosity and dilation also. Now unilateral I said very importantly because you see this is a case which was given in an exam. In COVID times we had this online sort of exams. So here you can clearly make out the tortuosity, dilation of the major vessels. You can make out the hemorrhages. Some asteroid hyalosis is obscuring the things. But many residents were diagnosing this as moderate NPDR. Now I have not shown you the other eye here, but the other eye was normal. So that is one big clue. You see, diabetic retinopathy is a very symmetrical disease. If you have other eye also findings, this eye also findings, you can have a confusion. Sometimes you can have a vascular occlusion overlying a diabetic retinopathy, although that is rare. But when you clearly have one eye very normal and one eye having such features, do not confuse it, please. It is a simple central retinal vascular occlusion which is happening over here. Okay. To investigate it further, once the hemorrhage is resolved, like in this case there are not much hemorrhages, one can go ahead and do a fluorescein angiography to get an idea of the capillary non-perfusion areas, but it's not very essential. But just to show you, here we don't find in this image too many capillary non-perfusion areas happening here. So we are going to classify it as a non-ischemic variety. There are 2 varieties, ischemic and non-ischemic. So what do you understand by ischemic and non-ischemic? Where is the ischemia happening? So what is this vessel supplying or taking the flow away from? It is the inner retina. So you'll have ischemia of the inner retina. So what will die first? The bipolar cells and the ganglion cells rather than the photoreceptors. So it is like the optic nerve elements are getting affected first. So if it is an ischemic CRVO, patient is going to have an RAPD first. Patient is going to have a B wave of the ERG, which is going to go down before the A wave. And if it is ischemic, obviously vision is going to be less, so less than 6/60. And all the findings are going to be much more. So you will have many more hemorrhages in all 4 quadrants. So these are some simple things which were given by Harry. You have an entire list, you can read it. But it is very simple to know once you know where the pathology is happening. And that way you can distinguish between an ischemic CRVO and a non-ischemic CRVO. Why you need to differentiate? Because ischemic will have a worse prognosis. Even in today's era of anti-VEGFs, whatever you do, ischemic CRVO is going to have a worse prognosis and a chance of worsening more, developing complications such as neovascularization of the iris and neovascular glaucoma much more than a non-ischemic CRVO. So in this angiography and in this photograph, I would say the findings are not too much. FA not showing so much capillary non-perfusion. If I tell you the vision of the patient is 6/36, so in the exam I will be happy if you say the diagnosis is non-ischemic central retinal vascular occlusion. And please note diabetic retinopathy over here. So again, second point to note in diabetic retinopathy would be diabetic retinopathy primary thing is microaneurysms. So more of microaneurysms, unless you see microaneurysm, that is the synchronon diagnostic point of DR. Unless you see that, you don't make a diagnosis. CRVO microaneurysms will come, but they will come later. BRVO again microaneurysms will come, but they will come later. They are not the first insult. They will come as a subsequent manifestation of the ischemia. So you have to look at how the pathology is working. Then again you do an OCT that will help you decide management. If there is significant macular edema, yes, even if it is non-ischemic, we will like to treat it with the anti-VEGF in today's era. So another photograph I'm showing you here. So this case again, time has passed, so the hemorrhages have resolved, but you can see here cupping is also significant. So these vascular occlusion patients, glaucoma is a significant risk factor in them. You should look out for a primary pre-existing open angle glaucoma. So in this angiography, you can appreciate many more capillary non-perfusion areas. So like sir said that we learn from studies, but patients may behave differently, but at least studies tell us the natural course of the disease. So first you have to know the natural course of the disease, then you compare it with the first treatment modality, then a second treatment modality comes which says that I am better, but you cannot use it unless you are able to prove it. So the natural history CRVO study is very important. That is what initially told you which cases, how they will behave. Should you just observe them or should you start treating them? I'll come to that a little later. First, just some investigations when you see a patient of CRVO. If it is an elderly patient, why is CRVO happening? It is basically mostly a thrombotic disease as opposed to an arterial occlusion, which is mostly an embolic disease. When does thrombosis happen? 3 simple things. Either the flow is slow, or the endothelium is faulty, or the coagulation factors or platelets are faulty. So if some of these are going wrong, a thrombosis is going to happen. It can happen either just simply because of age, or much common in diabetics, hypertensives, hypercholesterolemia. That is what you need to investigate. Rarely with CML and all patients, so that also you can check for. Young patients, you can have the other rare causes. Rarely we investigate for them because we rarely find them. But yes, if you have a young patient and patient can afford, then you can please go ahead with all these investigations also. For ocular management, 2 things are happening. The flow is getting slow, so there is macular edema. And second thing is ischemia is happening, that is leading to neovascularization. So these are the 2 things which we need to manage. So like I told you, from the natural history study, they compared with grid laser CRVO study, but they found that laser did not give any benefit. So they said that till I was almost a senior resident, what we were doing was nothing but observing these patients. Then anti-VEGFs came into the picture, which dramatically changed it. So there are studies which showed that anti-VEGFs can lead to improvement of vision by reducing macular edema. But again, like sir said, we are not going to treat the OCT here. It's not that you give an anti-VEGF, from 450 it is becoming 250, okay, keep on re-injecting. Patient's vision is not improving at all if you are giving 3, 4, 5 injections. So at one point of time you have to take a decision and stop the injections and not just keep on continually treating the patient just because of his OCT is improving. Okay, so if the patient is already a bad ischemic CRVO, probably at one point of time there is no point treating that patient with anti-VEGFs. Other option is steroids. So there is a SCORE study which has compared the steroids, and that has said that 1 milligram intravitreal steroid triamcinolone gives better results, lesser complications. So they have said that the standard treatment can be changed to steroids. So that is another thing which you can consider, but steroids always have the drawback of cataract and glaucoma. So that is why in most of the diseases, vascular diseases today, our first choice is generally anti-VEGFs, and then we switch over to steroids, barring some exceptions. Grid laser is definitely out. For neovascularization, again, like it was discussed in diabetes, we have two options, anti-VEGF or PRP. So the CRVO study said do definitely PRP once you see some amount of neovascularization of the iris, and that is still the golden rule followed today. So we will still do PRP once we see NVI. If you want to do it before that, then it is based on some new papers, but that is again not for you. Maybe that has some other, you can discuss it, it has pros and cons. But as a standard treatment, please remember PRP for a CRVO, we will still recommend once you develop NVI. You can initially manage it with an anti-VEGF injection, inhibit it, but you have to add a PRP again if you don't want it to come back again. Okay. So this is again an old patient of CRVO.
The only thing is that in that, go back to previous slide, is that with or without glaucoma it can happen. You see NVI, NVG.
Yes, yes. So I have not written glaucoma here. It will lead to glaucoma. But if you don't treat it, it will definitely lead to glaucoma. Okay. So this is just a collateral at the disc, which is a sign of an old CRVO. So you can see still make out some of the tortuosity here, no hemorrhages and all, everything. But a collateral at the disc with some venous tortuosity dilation is a sign of patient might have had old vascular occlusion. So this patient comes to you, vision is 6/60. How do you explain it? So simply if you see this, you know, and actually this patient also has a lot of glaucoma, but still you know that this patient has a CRVO. So from CRVO you go to BRVO, the same findings but limited to one quadrant. If it is limited to one major vessel, it is a supratemporal branch retinal vein occlusion. Same way you can see the fluorescein angiography. Now again, as the time goes by, hemorrhages will start absorbing, but you will, and the secondary changes will start coming in. You'll start seeing hard exudates, you'll start seeing soft exudates, but again limited to one quadrant, you see. So again, this, please don't make it diabetic retinopathy. This is limited to one quadrant. So, and you can do an FA, you can see everything limited to one quadrant. It is a branch retinal vein occlusion. Now again, going back to your initial studies, BRVO study, comparing the natural history, what does it say? Do you want to laser? So again, you will want to laser for two things, either macular edema or neovascularization. So if I talk of the CNP areas here, the study said more than 5 days diameters of CNP are there. There are higher risk of neovascularization, but still they said observe, do not laser. They said again laser only once NVE develops. So we'll probably still follow it to a large extent today, but Optos angiography has shown us a lot of retina, and the 5 days diameter rule doesn't apply that much today. So if we are seeing very significant areas of CNP, sometimes we go ahead with laser much before NVE also. But yes, that should be kept as a baseline in our mind. Okay, now this is another variant of BRVO where the major arcade is not involved, but all the changes are within the arcade. So this is a macular BRVO. So this is another variant of BRVO, just to show you the image. So this is what I was talking about. Once you have neovascularization, then yes, definitely no one can argue. There is a definite need for a scatter photocoagulation in this patient. And the second thing about macular edema is the same. So the initial study said that most of the patients after 4 to 5 months, they might become 6/12 or better on their own. So just observe. But if after 4 months they do not, you go ahead with a focal laser in a limited quadrant. Again, this changed with anti-VEGF. So anti-VEGF has proven to be better. So we have shifted to anti-VEGF treatment. But again, keep in mind that if your patient is definitely progressing and becoming better, so at one point of time, you can stop the injections and observe the natural history of the patient. Same way with steroids. Now the steroid, as opposed to the CRVO study, in BRVO they have not found a significant advantage. So intravitreal steroid, at least by the core study, says do not shift over to steroids as opposed to your observation or your focal laser. But there are other studies of Ozurdex and other implants which have shown improvements in vascular occlusions. So we always have to try and balance. Some patients which are throwing up edema again and again, there maybe we want a longer duration of action, and then we shift to steroids. So this is just to show you how you can do scatter photocoagulation, and where you can also make out the areas which have been left out. And if you want to augment laser in certain cases, this wide field imaging can be helpful. same investigations. Because of shortage of time, I will not go much into this. Okay, coming on to arterial occlusion. So a cherry red spot with whitening of the surrounding retina. Here ciliary retinal artery is sparing this area. So this is an easy diagnosis, central retinal artery occlusion. And in OCT you will see the hyperreflectivity of all the retinal layers happening. So like I said, this is more of an embolic phenomena. So what you would like to do is an echo of the heart and a carotid Doppler. In US, they also suggest that it is like a mini stroke, do an MRI brain, but we are not doing it in our center. And also look for the systemic general risk factors. So guarded prognosis in this disease, we can't do much. If patient has come very early, please try and do an ocular massage, give some pressure on the eyeball and closed eyeball and release it. Sometimes you may be able to release the embolus, or try lowering the pressure suddenly. That also might try to release the embolus, but all this may not be fruitful after maybe 24 or 48 hours of the onset of disease. People have tried various things, like I mentioned, even vitrectomy, but all these are just under trial, and none of them have actually shown a significant definite benefit. So just one case I wanted to show. This patient had had a triamcinolone injection for a skin disease in the face, and these are the triamcinolone emboli, which are causing this vascular arterial occlusion and also choroidal occlusion. So this is an amylaric sign, just triangular areas of hyperfluorescence, and so this is an underlying choroidal ischemia also happening in this patient. So it's not just that the emboli can come from the heart, they can also be extraneous substances, even talc, even blood injection users, septicemia, all those things can also cause emboli and cause arterial occlusions. So again, if it is limited to a particular quadrant, it will be a branch retinal artery occlusion. Please don't misdiagnose this as cilioretinal artery occlusion. You see there is a clear-cut space between the disc and this, and probably this is the junction where the embolus has blocked the artery, and the entire area of perfusion is very different from a cilioretinal artery. So this case, anyone wants to make a diagnosis? Okay, so sir is the super expert. So this is not just a BRAO happening, but also you see the venous tortuosity and dilation. So it is a BRAO with a CRVO. So there are two things happening in this patient. So sometimes you need to have a look at this. So this is a cilioretinal artery occlusion, just to show you. And this was the angiography pictures. Let me not go into much detail. But again, this is a cilioretinal artery occlusion with a CRVO, and it is a very well-known entity described by Harry. Why it happens? Because the probably perfusion pressure in cilioretinal artery is lower, and once the CRVO happens, the pressure exceeds the perfusion of the cilioretinal artery and causes a combined sort of occlusion. So that also, please be aware of this entity. Just to touch on a very new vascular entity which has come up these days. So patients come with some blurring of vision. You see some subtle white spots. It's not a total whitening like a central retinal artery occlusion, but when you do an OCT, what you find is there is hyperreflectivity in the middle layers. So here the intermediate plexus or the lower plexus is blocked, and this is now being, this also can be seen very well in OCTA, this or the on-fast imaging, where you can see furning around the vessels, this hyperreflectivity. So this is now being referred to as paracentral acute middle maculopathy. It's not an entity. It may be associated with other types of vascular blocks, or it can be an entity on its own. And some of these patients do recover well if it is an isolated entity. So just another type of vascular block I wanted to show you. Thank you. Thank you very much.
Thank you, Rohan. Very appreciative of you to finish the lecture only by color photographs, no textual slides at all, and very appreciative that you have listed a lot of very, very important points in this vascular disease. So time is not on our side, so we'll go on to the next talk, which is on OCTA, because all of us have been talking about dye-less angiography. That this is OCTA is known as dye-less angiography, that without injecting fluorescent dye, you can have nearly the same information as FA. So I said nearly means like leakage you can't see on OCTA, but CNP areas, neovascularization and segmentation of the various pathology can be done. So we have with us this from Shroff Eye Center, Dr. Gagan Bhatia will tell us about this OCTA.
So good evening, everyone. I think after this rigorous lecture, I think I remember my days 13, 14 years ago when I was sitting in the same hall and attending DOS teaching program. So coming to Okta, so I would basically be talking, I obviously cannot cover whole of Okta, but basically we're talking about how Okta is changing the practice, or how I'm learning to use Okta in daily practice. So coming back to, many years ago, there was this gentleman, 64 years old, who came for a routine checkup, and this was just post my own fellowship. And with so he came with this images. I think left eye had some kind of mottling in the left eye. The right eye was absolutely normal. He was sent for observation. He came 3 years down the line again searching for me, and there was this sliver of fluid in the right eye, and there was few cystic spaces in the left eye. Now at that time, Okta was obviously not there, and then we did a color photograph, showed some kind of pigmentation and little bit of scarring and RP atrophy in the left eye, whereas the right eye was not showing much change. OCT again, angiography again shows some sort of a little occult leak, and the right eye showed some sort of, again, a leak which increasing hyperfluorescence. Now, obviously, didn't think of CSR, did think of CSR, but then thought also probably there's a CNVM there, gave him anti-VEGF, nothing happened. And then by this time he was pretty upset, and his vision was going down and the waviness was increasing. So basically again did an ICG that maybe you're missing out on something. There were no polyps again. Did an ultra wide field AF and found these kind of things which confuse the image even more. Then I referred to somebody for an OCT angiography and found these two dots. At this time, I never knew what was to be seen in an OCT angiography. To add to the confusion, I sent it to my dear senior, Dr. Vinod, who found out this new terminology with 528 micron thickness and termed it as probably something related to pachychoroid. And this is when I started understanding Plex Elite, which is the OCT angiography, and picked up these very beautiful networks on OCT. So treated them with ILIA, and rest was history. So this is where I started taking interest in OCT angiography and started seeing all these patients. Initially, I never used to understand what is going on happening with OCT angiography as well. So what is OCT angiography? It is basically a non-invasive tool which basically uses the motion artifact. So basically uses the blood flow in the channels to obtain volumetric data, and which generates basically angiographic images which both structural and based on the blood flow pattern in tandem. So basically it helps us to kind of divide the retina into 4 zones, which is the superficial, the deep, so the superficial plexus, the deep plexus, the outer retina, which is known as the avascular layer, and then is the choriocapillaries. So basically dividing the stalk into things that we see in the superficial layer and then things which we see in the deep layers. So coming to the superficial plexus is on the left, which are basically hyper-intense vessels which show a very regular pattern, and in the center you can also see the foveal avascular zone. The deeper plexus is more close-knit vessels which again shows the foveal avascular zones, and it has interdentations of the horizontal and the radial interconnections. So what changed with Okta in the superficial layers? So coming to first is diabetic retinopathy. I think we've heard so much about diabetic retinopathy. Yes, everything can be diagnosed on a fluorescent angiography. You really don't need an Okta for diabetic retinopathy. But where do you need? You need where there are leakages. Now, if there is a leakage here, so on the image on the left, if you see there is so much of leak, you really can't make out why the patient is not improving. You know, the last speaker was Dr. Rohan was just telling, you can't keep injecting even if they're not leaking. Now, if you see the Okta is where you see that there are the flow void areas or areas where there is no perfusion. So basically it helps to pick up macular ischemia a little better in few cases of diabetic retinopathy. Then this is again a patient who came with a renal transplant. So I think with the increasing disease of diabetes, I think diabetic nephropathy is very, very common, and fluorescent angiography sometimes is not done. And usually these patients are really ignored because otherwise they have multiple problems. They're going for dialysis and you really don't want to touch them, and they also don't come back to us. But then if you see this image, I think you all have just learned the classification of diabetic. If you see there are just one or two hemorrhages here and there, right? And you would just tell him, okay, he's fine, go ahead with your dialysis, and we don't need to do anything for the retina. But if you do an Okta, this is what you see on a wide field angiography. You pick up a new vessel. So there is basically a new vessel over there. This could have been very well picked up, yes, on a fluorescent angiography, but Okta just give you an edge where fluorescent angiography cannot be done. And you can also see that the image on the right basically shows us the VR interface. So basically, if you're picking up a new vessel and the VR interface means that it is an elevated new vessel, and you should basically not be bombarding it with laser directly, whereas you can go around it. So it kind of plans your PRP, especially in these cases, because ultimately you end up with a vitrectomy in these cases. Again, they have systemic issues which can be avoided. Again, in the left eye also shows this kind of a new vessel, and this is a wide field image of a PDR patient, again with nephropathy, and you can very well pick up the new vessels over here. This was published by us, where again you can see post laser that there was a regression of the vascular pattern. So the left image shows you the NVE, which is kind of decreased, and the right image, which is a B scan, which shows you that the vascularity, or the red color, is the flow. So the flow has basically decreased in that post the laser. So this was just to show you that it is not all fluff, but you should also, if you have access to OCT angiography, you can probably see all these angiographic images and you can compare it with your angiography to just learn better. This was, again, there was regression of the whole NVD network. You can see on your left, and it regresses on the right image. Now coming to retinal vascular occlusion, I think Dr. Rohan has already spoken about it, but again, it kind of, you can see those bedewing, you can see the vascular loops, and it defines the focal, the ischemic area in the center much better if you have a lot of leaking which is happening on the angiogram. This was again a patient, so he was talking about ischemic and non-ischemic CRVO. What I have seen is that Octa basically is able to pick up these CNP areas a little more better in an acute phase, more than FA, and you can see, and this is very well documented in this patient, where within 6 weeks this patient converted from a non-ischemic to a ischemic disease. So then again, I think somebody was talking about featureless retinas, and featureless retinas, again, usually these patients have multiple systemic problems as well, and they usually get are sent back saying that nothing can be done or this disease won't progress. But then in these cases, again, Octa will help you where regular angiography cannot be done, and you can see these massive areas of no vascularization and normal vessels. So now going deeper, so we have, so the basic, these two diseases, which is a superficial disease, which is basically diabetes, where in diabetic nephropathy it helps, and vascular occlusion, where you can delineate the CNP areas in the earlier disease. Now going deeper, we come to the avascular zone, which is basically just above the RP, and then the choriocapillaris layer. The avascular zone is mostly darker, it is more homogeneous, but it has got bigger vessels, but it appears darker because of the flow void, because of the flow artifact, and then you have the homogeneous layer, which is the choriocapillaris layer. So I think you've had a lot of lectures today right now on this, but at this stage, I think my suggestion would be that to learn Octa is to sit on the machine. Because if somebody initially, when I used to sit on the machine, see somebody used to show me a network, I used to just think, okay, there's a network, I've already seen the leak, so why see the network, right? Because I know that, okay, you have to give an anti-VEGF, but the point is to sit on the machine and see these networks, learn the sectioning, so you will have different form of networks. These can be asked because you have the glomerular type, the medusa type, and so today only I learned that, there was an article which I was reading which says that myopic CNVMs usually have a glomerular pattern with a halo around it, and that's one of the pathognomonic signs. So you can characterize these CNVMs as you have been told on Octa by type 1 and type 2 neovascularization. Type 1 usually are more hyper-intense, they are more larger, and type 2 CNVMs are basically with thinner filiform kind of vessels which are above the RP, and type 1 are below the RP. So idea is that you sit on the machine and kind of categorize these CNVMs because you already have angiographic images, you have the theoretical knowledge, but if you see these images, and you can better follow up these patients and also increase your understanding on Octa. So then there is the type 2 CNVMs. These again, they just look like some stippled hyperfluorescence on the FFA, and it becomes very confusing. I understand at this stage it is still again about treating with an anti-VEGF, but still if you pick up these CNVMs, I think the classification systems are changing, and picking them up at this stage would be a good thing. You can also document regression of neovascularization on Octa, and sometimes these membranes do decrease or disappear. I think one lesion which I think Dr. Avnender had talked about, and he had shown you those images which goes from the choriocapillaries to the anterior part or up to down. So if you can document this again on on an Octa, it will give you a better understanding of the disease. So if you see that, if you go from the deeper plexus to the avascular retina to the choriocarpales and to the feeder in the choroid, so you can kind of map it all across. And this wrap I never ever understood many years ago, for many years, because it just used to look like some leakages here and there, and rather I used to always diagnose them as TRVO, because there was 1 or 2 heme spots, some abnormal vessels, and hard exudates, and I used to always think this is a TRVO, right? And this is where Octa kind of really changed the perspective, and I started understanding the disease pathology more. So then obviously where we started, which was CSR, I think CSR is one entity which Octa has definitely changed. I'm not going into this thing, but if you see this kind of a CSR, I would have never thought that there is a network in this. But there you can pick up a network over there. Then there is multifocal CSR. Now multifocal CSR, as far as my teaching and understanding goes, I think there are various trials, various theories, and you can kind of treat them, but never thought that you will pick up a network even in these multifocal CSRs, and they could also be treated with anti-VEGF. And if you see in the later frames also, again, you can pick up these big glomerular kind of networks in a case of multifocal CSR, and these are just not projection artifacts, because you can see a feeder vessel also going in the deeper layers. Then this was again a confusing patient which came with fever, and there was this kind of a bruising which was happening in the outer retina. Didn't know what was there, and probably some sort of epithelitis which was happening. Patient was observed for some time, and then when we just did a Octa, just by chance we picked up a network over there. Best disease. This was one of the most chance findings. My knowledge always went to egg yolk coming, egg yolk going, and that's all. And that is what my teaching was, or what I learned during my residency days. But then yes, you can pick up networks. I think treatment, it's still debatable as to how long you treat, till when you treat, and what should be the gap in treatments. Coming to IJT, I think Dr. Avnender had talked about this condition again, but yes, nowadays you can pick up. There is the OCTA has kind of differentiated IJT into 4 grades, and there are grades where you can pick up networks on a OCT angiography in IJT. Even I personally have treated a few patients, but again, the question is that what are the indicators for treatment? So I don't think we need to go into that. But if you see a patient of IJT and if you have access to the machine, go ahead and do this thing, especially if they are suddenly come up with decreased vision, or they come with a heme spot at the retina. So this is the classification. I'm not going into that too much. PCV, I think this PCV is not something which needs to be diagnosed on Octa. So why I included this was because I was asking a question in one of the in the journal clubs, and I just asked, okay, what do you diagnose with Octa? And the first answer was PCV. No, PCV is not diagnosed on Octa. Why? Because it is a volumetric study, and the flow in a PCV is very slow, right? So PCV is not something which is diagnosed on Octa. Yes, you can pick up polyps, but at this stage also, I'm not very confident picking up polyps in every disease. I think ICG is the modality of choice to pick up polyps in a PCV. Though I have documented this also. And the only thing which I feel Octa helps is the BVN. So the BVN network definitely shows change on an Octa, and this kind of helps us to increase the treat and extend time when there is no leakage, there is no CME on an angiogram and on an OCT, but you see the BVN network which is kind of increasing even with extended treatment. Pachychoroid neovasculopathy, I think Dr. Jha has covered extensively, but this is how you can pick up a network on a PNV. And this is again one of the things that it was just playing with the machine, and this was a case with multiple drusen's with some drop of vision, and we did an OCT angiography because I suspected that maybe there is some heme spot, and we picked up a very beautiful network over there. So just to kind of defining Octa at this stage, I think it is just basically about defining CNVMs. I think obviously the terminologies type 1, type 2, type 3 is something which is important, but picking them up with what you know is going to teach you more than just thinking, okay, there's one type 1, there's one type 2, and there's one type 3. So that can be done. I think understanding CSR, I think CSR is definitely changed with Octa coming in, and those patients, I think should be undergo a OCT angiography. Diabetic retinopathy, I would change it to diabetic nephropathy more. I think those patients also can be taken up, and we should not go for arbitrary laser or even delay the laser, both ways. And also studying the FAZ. I think RVO, this is something which I have found that it detects the CNP areas earlier, and IJT and Best disease is something which is now coming up and which I think is beyond the scope of this class, but I think this is something that we should also look forward to. Thank you.
Thank you, Gagan, for highlighting the importance of Octa. And believe me, times are changing. FA has reduced, Octa is gaining more importance. And as of today, I don't think so FA is dead.
No.
But Octa is making it, nearly that.
I personally feel that if somebody wants to learn Octa, they should not leave the FA.
So we learned that,
Yes.
sit on the machine,
Exactly.
for a long time.
Yes.
And unless you do that, you don't
Yes,
learn
and
Octa.
sit with your color photo and sit with your FA and then compare the lesions, and then you will kind of
I hope
define them better.
people in clinical medicine have that kind of time. We normally do not have that kind of. Yes, Shashi.
I think Octa is a very good thing, but I think what we have seen, because of the fear of injections, people are deferring FA in diabetic retinopathy.
Yes, they should not be
Kindly call your anesthetists, but do fluorescein angiography in all diabetic patients.
Yes.
Octa is not the answer in diabetics, and Octa you will not be doing in many patients, but fluorescein angiography is something which will save your patient's eye. So fluorescein angiography should be taken more seriously, which people somehow are avoiding. OCT, injection,
at least you should be able to tell in the exam that FA should be then that is
Yes.
and what are the indication, what are the findings. That is sufficient for me.
In any case, I had, once in the second talk, I had said that FA at the baseline, especially in a featureless retina, in 5 minutes will give you a wealth of information, whereas in other modalities, you must struggle to pick up all the findings. So we'll have, we covered all the adult disease, but somehow pediatric got left out.
And
we
child
have,
is always
we have
ignored.
We have the best person for ROP, that is Dr. Parijat, and he exclusively does ROP.
He doesn't touch adult, and he is only fond of children's.
So I'm sure he will give us
less
lot
than
of messages.
Thank you, sir.
Yes, Parijat.
Thank you. So I'll be talking about ROP and how it's useful to you. So why has suddenly ROP become so important as a PG teaching system? Because I remember when I was a PG, I was not taught too much about ROP. And so what has changed in these last 2 decades, why it's become important for you, is because India right now has the highest number of preterm births in the world. And this paper is in 2012. So, we are having the largest number of preterm births in the world, and a large amount of babies are born preterm now because of improving NICU care, and they are developing ROP. So it's become a huge public health problem in our country. So right now we're in the 3rd epidemic of ROP, which is happening in the lower middle income countries. It's basically happening because of improved survival of these babies, and it's happening because of poor NICU care. And India, because of its large population, is the most hit with ROP. So ROP basically is retinopathy prematurity, which is basically retinopathy, which happens in preterm babies. And basically the vessels stop growing into the periphery, which would have happened had the child been born full term. So the basic risk factors are prematurity and low birth weight, although there are a lot of other risk factors which are there, but these are the primary 2 ones which are the cause of the problem. So very recently the international classification has again been updated, and the 3rd edition has come out, which again updates some small nuances which I'll just come to. So we are well aware of the zones of ROP. Basically the smallest zone is the zone 1, which is the smallest circle which you see here. It's twice the disc fovea distance. The circle outside is the zone 2. It touches the nasal ora serrata, and the outermost zone is the zone 3. So there are 3 zones of ROP. Zone 1 has the most severe disease, zone 2 has the most common disease, and zone 3 will mostly regress. So the recent ICROP update added the zone 2 posterior, which is a zone 2 disc diameters outside the zone 2, which basically indicates that this disease might be more severe than what was expected in zone 2. So that is another zone 2 posterior terminology. This is another terminology introduced in zone in the ICROP, which is the notch. So you see the disease here is in zone 2, but it is going into the zone 1 because of the notch. So in ROP we take the smallest zone of the disease. So here we have to say like zone 1 due to notch, right? So it indicates it's a more severe disease than what zone 2 disease would normally look like. So we should be aware of the stages of ROP. The stage 1 is a demarcation line. So it's just a junction between the vascular and avascular retina. You see a fine line is there. Stage 2 is a ridge because it becomes thicker and more wider. Stage 3 is extraretinal neovascular proliferation, which is going into the vitreous. So the keyword here is extraretinal, it's going beyond the retina. Stage 4 is basically partial retinal detachment. Stage 4A when the fovea is attached, stage 4B when the fovea is detached. Stage 5 is total retinal detachment. The ICROP3 further divided stage 5 into 3 parts. It's now known as stage 5A, where the optic disc is visible, stage 5B where the optic disc is not visible, and stage 5C which is filled with anterior segment changes, which could be posterior synechia, shallow anterior chamber, corneal opaquity, etc. So this is the plus disease. Plus disease is the third integral component of classification besides zone and stage. Plus disease basically means dilation and tortuosity of blood vessels at the posterior pole, and it signifies activity of the disease. There's another terminology known as pre-plus disease. It is less than plus but more than normal, and pre-plus, as the activity increases, can go into plus disease and become an indicator for treatment. This is another important component which is known as aggressive ROP. It was previously known as APROP or aggressive posterior ROP. It has again been changed in the recent terminology to aggressive ROP or AROP. It basically signifies a disease in which you don't see anything at the junction. So where is the stage 1, 2, 3? Nothing is there at the junction. What you see basically are these kind of loops. These loops tend to confuse the best of observers because you are waiting for the ridge to come. Stage 1, 2, 3. Nothing is coming here. It's basically a bunch of loops which is there. It's a very severe form of disease, happens in the posterior zones and can progress very rapidly to blinding ROP. So it confuses the best of people, and we have to have a strong index of suspicion for aggressive ROP. So since we told you that a lot of these babies are going to develop ROP, how to detect them in time? So it can only be detected in time by an ROP screening program which runs in the NICU. There's no other way to detect it because it's not visible from outside. So the first question comes to your mind, whom should you screen for ROP? So the US guidelines say you should screen babies less than 30 weeks of gestation and less than 15 grams of birth weight. But in lower middle income countries, why the third epidemic is happening? Because although there is one set of nurseries where, in top hospitals where, improved survival is happening, so ROP is happening in smaller babies. And on the other side, there's a mushrooming of a lot of NICUs across the country where poor NICU care is happening, and therefore bigger babies are also developing ROP. So in countries where, screening facility is already poor, if you have a double whammy here because, not only smaller babies are developing ROP, bigger babies also developing, and the screening service is not there. So that is leading to a lot of blinding ROP happening in our country. So the RBSK guidelines are now what are followed in India. These are the national ROP guidelines created by the RBSK, the National Program for Control of Blindness, and the National Health Mission. So these are the guidelines which have been released in 2017, and basically what they say is that you need to screen babies less than 2 kg of birth weight, less than 34 weeks of gestation age. You can screen bigger babies as well if they have these multiple systemic risk factors. So this is what you need to remember, because this is what will be asked in the exam if a case of ROP lands up. Less than 2 kg, less than 34 weeks. And when should you screen them? You should screen them within 30 days of birth. 30 din roshni ke. If you remember that, it will be easy to remember. 30 din roshni ke. And further, the RBSK guideline says that if you have got a very small child, less than 28 weeks, less than 1200 grams, then you can screen them as early as 2 to 3 weeks. So these guidelines you have to remember. You might not directly be dealing with ROP, but this is something which will routinely come to your OPD, and you need to know what the guidelines of screening ROP are. So screening is very easy. It's a very cost-effective program to screen ROP. You just need an indirect ophthalmoscope. The dilating drops which I use are half the adult dose. So either you can dilute them in half with tears, or you can get them custom made as is done in our place. And it's a very cost-effective, easy way to screen for ROP. Digital wide field retinal imaging has become very popular of late because of the availability of digital cameras. The RETCAM has been around for a long time. The Trinitra Neo is a made in India camera, and there are a lot of other custom cameras which are also becoming available in the market. The problem is that these cameras are very expensive, so a RETCAM will cost around 80 lakh rupees or more, and therefore it's become a very limiting thing. The idea here is basically you put a gel and put the camera over the eye, and the photo comes in the screen. So the use is basically, it's useful not only for teaching and training purposes, useful for documentation and follow-up. And the biggest advantage with this is happening is for tele-screening programs. So this is a KidROP program happening in Karnataka. There's a GujROP happening in Gujarat, SAMROP happening in UP. So a lot of these programs are happening now. But the mobile van goes across the different cities, screens, sends to a reading center, and the people, through the apps can, decide what to do with these babies. Treatment of ROP, basically 3 different modalities available: laser, anti-VEGF drugs, and surgery. Laser has been around for a long time now. So the early treatment ROP trial, or the ET ROP trial, is what gave the guidelines for laser of ROP, and stood the test of time over the last 2 decades and leads to excellent regression of ROP. So this is just a chart to show here that basically what the idea is that you'll see that zone 1 needs to be treated. Zone 2, if it got plus, stage 2 to 3, you need to treat it. That is the idea. The idea is to treat the avascular retina, which is basically the stimulus for the ROP. So you do laser in the avascular retina and the disease will go away. However, laser in aggressive ROP is challenging, because just to show you an angiography here, that you see the blue line is where people will think the junction is, but the red line is actually where the junction is, because all the area in between is all avascular loops, which are very characteristic of aggressive ROP. So people who want to do laser in ROP, aggressive ROP especially, should be very aware of this kind of picture, that this could be there. So this is how aggressive ROP traditionally used to be lasered, and had you shown me this photograph 5 years back, I would have been very happy that, you know, a very nice laser has been done in this case and the disease has regressed very nicely. But you see, in 2023 there are a lot of problems in this photograph right now. It's got a limited visual field, poor macular perfusion, and there's a risk of high myopia with so much of laser done in these eyes. So can we do better than this? Is there a better way for laser, the way forward? So anti-VEGF drugs have now emerged as the first line of treatment for zone 1 aggressive ROP. It has rapid ROP regression. It causes retinal revascularization, which laser could never do, which will lead to a better visual field, better foveal structure, and lesser refractive changes. Moreover, it's a much faster procedure, can be done by a lot of retina specialists. Laser was technically very demanding. Doing 2 hours laser with severe pain happening in the baby, you know, crashes many times during the procedure. This is a much faster procedure in comparison, and a much more stable baby will be the result of this. So just to show you a photograph here, you see this has got extensive neovascularization happening in the pupillary area. Now you can't do laser, can't do surgery, can't do anything in this eye. If you inject in 3 days, you know, the pupil will dilate like this, and then you can do whatever you want. So this works like magic, works very fast in ROP, because primarily the problem is happening with the neovascularization. You see a case here, a very small, you know, retina has grown in this case. This is zone 1 posterior, as we like to call it. Even the macula is not vascularized. So you can't really laser these kind of cases, which we used to do earlier. You can't, some people like to do posterior sparing laser and all. Whereas if you inject these cases, you know, in 6 weeks, this is what it will look like, and the retina continues to grow even further. So this is the huge advantage of anti-VEGF, which laser never had. So which drug to use? So a lot of the drugs are there. People have used Avastin. Avastin has a lot of literature, but right now a lot of people are using ranibizumab, use biosimilars, ranibizumab as well in these eyes, because that's in the hospital supply. It works as equivalent to Lucentis, which we had earlier. Usually half dose is given. So just a word here. So ranibizumab has regulatory approval in the European Union for ROP. Recently, Eylea has also got FDA approved for treatment of ROP. Half dose is what we use, and that is the most literature on it. And usually 1 injection works very well, although there are some indications for second injection, which I don't want to go into now. And you have to inject, we inject in the operation theater in sterile conditions in the magnification of the microscope. That works best and will prevent a lot of complications like cataract and endophthalmitis, which happens in these cases. So the bigger problem right now is managing reactivation. You can't let these babies go because the effect of the drug is limited. In 4 to 8 weeks, the disease has a tendency to come back. It can come back with a lot of vengeance. So if you do not, follow up these cases closely, and the retina has not grown fully, then there's a high chance the disease can come back. So you need to be aware of it. You need to closely follow up. If the reactivation happens, then you can go ahead and do laser. If the disease is a small amount of retina has grown, then possibly some people like to give a second injection as well in these cases. If the disease does not reactivate in a significant peripheral avascular retina, this is again a terminology in the ICROP3, peripheral avascular retina, PAR is known as. So if a lot of PAR is left after injection, then again there's a chance that a late reactivation can happen. Late reactivation has been reported after several years after injection, and therefore it's better to, if you've got a significant PAR at 10 to 12 weeks, to go ahead and laser the PAR, and so that the disease does not come back with a late reactivation. What is the role of ROP surgery? ROP surgery is a challenging situation, and hours can be spent just looking for an IV in these small babies. You need a small, extensive NICU backup to take care of these babies. Results of surgery are very good if the children come in time. So this is a stage, you can see it's a stage of 4A. If you operate these eyes, then the disease can go away very quickly. So the left photo is already too late, So if you want to refer, the idea is to refer early and not keep on praying that the disease will go after laser or injection. If the disease progresses, better to refer early when the traction is low and the surgery can be done in a much better manner. Just to show you just quick steps, this 25G lens sparing vitrectomy has been done. The basic principle here is to remove the traction which is happening in the center, joining the disc to the TRD, which was going to cause the falciform fold. Remove the traction over the TRD so that all this retina can fall back. You can see laser marks temporally, and then below that is the circumferential traction. You cut that in the center, and all this is going to fall back. That is the key idea here. Don't worry about the bleeding. You can go ahead and dithermize because we're cutting vessels into the vitreous. So you have to go ahead and dithermize all those vessels. So this is just in a situation which we are getting very frequently right now. You see the child is lasered. He's already, an extensive aggressive ROP with stage 4A, and a lot of, neovascularization is happening here. So if you do a surgery alone in these eyes, it's going to lead to a lot of bleeding intra-op, post-op, as well as going to lead to a contracture later. So if you combine this with anti-VEGF at the end of surgery, then this kind of outcomes can be obtained which were not possible earlier without anti-VEGF. And obviously we like to operate both the eyes together in a single sitting because GA is very high risk for these babies, and operating both the eyes together works very well. Obviously you have to treat them as two separate eyes. This is just last 2-3 slides. So this is the stage 5 ROP. A lot of the babies come with this, and in today's age and era where medicine is such a stage, we get around 10 to 15 babies coming in stage 5 ROP. All of these are potential medical legal cases because there are national and international guidelines for ROP for the last 3 decades. It's not a new disease, it's an old disease, and if we still continue not to screen these babies and they keep on continuing like this, they're all potential medical legal cases, and lack of screening is the most important cause why stage 5 ROP is happening in our country. And if we see 15 cases at one center, you see what is happening across the country. And so this is just to show you some data, and out of around 30% of babies which come to RP center are afflicted with stage 5 ROP, and 89% of these were never screened for ROP, and 20% of these are coming from Delhi only. We're not talking about rural places here. And this is just to show you a very quick video of how we like to operate these eyes. So this is a clear corneal approach through which these eyes are operated. So this is 25G instruments going through a 23G MVR incisions, and you basically have the idea is to remove the lens and the retinal membrane. So this, you see these babies are left for blind. I'm just showing you a very simple case here. There are not much membranes inside. You just remove the membranes, remove all the posterior synechia, and if you just, as you continue to go inside this area, see the dissection is easy in this case, and there you can see the disc is there, the posterior pole is there, the retina is attached. So this is not a very common occurrence. This is a very uncommon kind of occurrence. But what I'm just trying to show you is that this kind of occurrence is possible. So otherwise traditionally the outcome in stage 5 ROP is very poor, and these babies are left for blind. But what I'm just trying to show you is that stage 5 surgery should be attempted in these babies in the hope for getting some kind of navigable vision. They might not be able to read, but they might be able to go from here to the bathroom without crashing along the way. They might be able to see their parents standing there, some social smile might come. So a lot of life changes happens once you give navigable vision to these babies. Even hand movement, finger counting close to face will make a huge difference to their lifestyle. And this is the last slide, and this is, I think, the most important slide of this presentation. That's a preventable cause of blindness. So if I say that 600, 700 babies are lasered in RP center every year, how many do you think of these will come from the AIIMS and ICU? Any guesses? Anyone? Any guesses? How many out of 700 per year will come from the AIIMS and ICU? 5. So I told you a lot about aggressive ROP. Let's say we are giving around 150 injections, 200 injections every year. How many of the injections are coming from the AIIMS and ICU? So last 20 years only 5 injections have come. Last 20 years. How many surgical cases I showed you? So let's say we operate around 200 maybe per year. How many of these come from the AIIMS and ICU?
None.
0. So I have not seen any for the last 20 years. I have not seen any surgical case because so the idea basically is to just tell you that although we agree that the AIIMS and ICU must be saving the smallest and sickest of babies, but if you have good NICU care, ROP does not happen. ROP is generated in the NICU if you have a very good NICU care. So there are very well defined criteria for good NICU practice. If that good NICU practice is followed, then severe treatable ROP does not happen. And even if it happens in a few cases, it can be treated.
The fault lies with AIIMS or fault lies with RP center?
The fault lies with the NICU, sir.
So therefore you have to generate facilities at NICU, na?
Facilities at NICU,
so
sir.
the
NICU has
senior resident from here should be posted in NICU. So then
so I'm saying AIIMS and ICU does not develop ROP, sir.
AIIMS have very little.
What we get at RP center
outside
is all walk-in babies from outside. They are developing ROP. So if you have good NICU care, ROP, treatable ROP does not develop.
So the moral of the story is do not miss. Believe me, these are all very good slides that prevent ROP. You see, a lot of court cases have gone if people have missed ROP. So you should have all the skill set to diagnose ROP early, so that Parijat can treat very effectively. And today, believe me, with the anti-VEGFs, it's not only laser and destruction. It is, I think, a combination of both, and which leads to virtually saving these eyes lifelong. If you miss the bus, believe me, it's a permanent kind of blindness. That's right. Yeah.
The point is that it is not the baby born early, it's the iatrogenesis. The obstetricians are operating CSA very easy, operating at 30 weeks onwards anytime.
So
No. All yes, we agree. Obstetrician are also responsible. That is the another factor. Obstetrician, yes, right.
So, okay, I think time is running out. It's nearly 6:45, and I thank all the 9 speakers, right from Vinay Garodia, Dr. Vinod, Ankur, Dr. A.G. Avninder Gupta, Shashina Jha, Rohan, Gagan Bhatia, and Parijat, and also thank the patience of all you who have been sitting till this time, and Alkesh and Rajpal for helping me conduct this symposium. Yes, Shashi.
I think because this is basically aimed for the postgraduate teaching, I think we should be focusing on what type of thing they will be facing in their exam. I think the topics should be absolutely basics, because when we conduct our exam, we see the gross, say, clinical part and how the viva they will be addressing and all that. And even you can carry out, see, of course, we are having DNV programs. So the OSCE has become very important for their passing out. So one of the sessions should in DOS teaching programs should be totally based on OSCE.
I 100% second this, because believe me, once you are, as I said in the beginning also, if it has to be a teaching exercise, you have to have more time. You can't just give 9-10 lectures in
like less of the lecture, but
1 or 2
more of
hours. And this has been going on in DOS for a very long time. And if you become the secretary, you should change this.
Right, sir. Done, sir.
Chal, Praful.
Yes, sir. We are taking that.
Yeah.
We'll take feedback.
Any comment from anybody?
Anyone? I think they are tired enough.
Patil, bolo kuch. Shweta, kuch bol nahi rahi. No comments. So we try to do our best so that we try to punctuate some of the messages which should go across. But should you have any questions, you can ask either directly or through Rajpal and Alkesh. We would be very pleased to answer any of them. So thanks a lot.
Well, sir, thanks to DOS for conducting at least this teaching program.
So should thank
Taliyan bajao.
So should thank Praful Maharana, because he was the person who made the entire program, and he was instrumental in ringing up everybody and getting us here. So
thank you all speaker for that. And if you people want to do wet lab tomorrow, please send messages to me or Dr. Anu Malik. Okay, and there is a dinner for you downstairs, so you people can stay if you still have some patience.
Praful has been doing a lot of this conducting wet labs. Even at AIIMS headquarters, you see, we have made Praful the coordinator primarily because he does an excellent job in conducting these wet labs.
Yeah.
Thank you, Praful, for.
Thank you, sir.